health for all. As always, we begin with one of the most important aspects of any gathering, kindly ask for an anthem. So sorry, we have to wait for the details.
दूसरा भी वो इसका वो पे वाला नहीं है, वो अली से जाकर ढूंढ रहे
वो
हैं।
ले गया है
और दूसरा फ़ोन वो मैडम वाला खोली करा।
कॉलेज वाला ले लो। इधर एक्सटेंशन लग गई
नहीं
Assalamu alaikum. Welcome to Dr. Said Medical and Dental College. We will begin momentarily with the arrival of the chief guest. Thank you for your patience.
कैमरे के नीचे जो वो लगा हुआ है ना, वो भी तो आते हैं। हाँ जी स्टैंड लगा हुआ। मैडम कौन चाहिए? फर्स्ट फ्लोर पे ऑडिटोरियम। एक सेकंड में से ठीक है.
I want to sit here.
सही से फेसबुक लॉगिन नहीं है, कौन सा अकाउंट मेरे पास है इसके अंदर? अपने पेज का कोई अकाउंट लगाना पड़ेगा ना. नहीं, इसमें एम है, लॉगिन नहीं है, फेसबुक लॉगआउट है. Door 1947. सबसे राइट को बोलना है। नहीं, इस तरफ दूसरी तरफ इस तरफ। और इधर ही सामने स्टेज पे राधा शब्द नहीं है, ये किसी की है।
Assalamu alaikum, ladies and gentlemen. My name is Abdullah Basra, a fourth year medical student. Good morning and a warm welcome to the annual scientific conference here at Dr. Said Medical and Dental College, where we gather under the theme for health for all. As always, we'll begin with one of the most important aspects of any gathering. Kindly rise for the national anthem.
Assalamualaikum, ladies and gentlemen. My name is Sameer Afzal from 4th year engineering. Now I'd like to call Ghulam Nasim for the recitation of the Gudi Quran. Moving forward, I'd like to invite Ghulam restoration of a beautiful north.
حب أحمد أزل سے ہوں میرا مدینے مد أزل سے تفیرے میں میں ہوں میرا مدینے میں
The college on the annual scientific conference 20 with the theme Health for All. Established in 2006, AMDC is one of the premier private medical colleges with a purpose-built spectacular facility situated in the heart of Bahia town, Lahore. Equipped with the state-of-the-art facilities and an environment that is conducive for the professional growth of our students and faculty, AMDC is where an inspiring doctor's dreams come true. We take pride in our infrastructure and teaching facilities. Our premises has full-fledged, functional and well-equipped medical and dental colleges, imparting quality medical education at undergraduate and postgraduate levels. This institution has 3 state-of-the-art tertiary care multi-speciality teaching hospitals affiliated with it. Farooq Hospital, Allama Iqbal Town, 110-bedded hospital. Farooq Hospital, Westwood, 250-bedded hospital. And Akhtar Said Trust Hospital, which is a 300-bedded hospital. All are equipped with the latest and modern and therapeutic and diagnostic facilities, including fully automated labs, PCR labs, specialized surgical and medical procedures like cardiac surgeries and renal transplants are done over here. Then we have state-of-the-art dialysis units and intensive care units providing or offering services to the masses. Another feather in the cap is Farooq Hospital DHA branch, a high-end 300-bedded tertiary care hospital that started functioning last year and is quickly proving to be a valuable asset to the healthcare services in DHA. Akhtar Said Medical College, Rawalpindi campus, and its affiliated 500-bedded Farooq Hospital was recognized by PMDC last year and is a new addition to our health sector. Other institutions of Farooq Hospital industries include Akhtar Said Pharmaceutical Sciences, 3 campuses. One is here in Bahia Town, the other one is in Westwood, and the third is in Rawalpindi. Then we have College of Rehabilitation Center, we have College of Nurses, we have College of Allied Sciences offering different programs like PSC, MLT, MIT, nutrition, etc. We provide the infrastructure, support and guidance related to health professional education and help them to move successfully through their career. With the rapid development in teaching methodologies, information and communication technology, medical education has become more dynamic than ever before. A productive learning environment and a highly qualified and reputed teaching faculty play a fundamental role in integrating innovative teaching, research and social accountability in our students to keep them at par with the global demands of this technical profession. Our students are also encouraged to participate in various co-curricular and extracurricular activities like sports, community-based activities, research, literary and welfare societies, etc. By the grace of Allah, our graduates have brought laurels to this college by consistently securing top position in the university professional exams and have been excellent ambassadors of our institution nationally and internationally. However, at AMDC, our emphasis is not only to impart up-to-date professional knowledge to our students, but also to inculcate compassion, integrity, accountability, and professionalism as the core set of values in our students. Medical conferences and workshops have played a pivotal role in advancing the healthcare industry by providing a platform for sharing knowledge, discussing innovative ideas, and medical advancements. We believe that this conference can make substantial contribution in dissemination of the latest scientific research and advancement of medical education in the healthcare setting. I hope the rich context of our scientific conference would be stimulating and academically beneficial for all and will leave you with fond memories. Last but not the least, I would like to appreciate the effort put in by Professor Dr. Agha Shabir, Chairman Organizing Committee and his team for successfully organizing and managing this event. Thank you once again, and I hope that this conference will contribute greatly towards continued education of healthcare professionals. Thank you very much.
Ladies and gentlemen, our distinguished panel present here today consists of professors, researchers, and presenters, includes experts from various disciplines, bringing together a wealth of knowledge, experience, and insights. Progressing forwards, we'll move on to an incredible personality, the Punjab Health Minister in the Senior Supervisory Cabinet of Punjab, a man with extensive experience in the field of health, a Vice Chancellor in 2 different medical universities, serving under prestigious institutions such as Benazir Bhutto Medical University, the University of Health Sciences, Allama Iqbal Medical College, Mayo Hospital, and Jinnah Hospital. I'd like you all to join me in welcoming our chief guest for today, Professor Javed Akram.
Bismillahirrahmanirrahim. Assalamu alaikum. My dear brother, leading the Healthcare Commission Punjab, Dr. Saqib Adeeb, the chairman of Askar Said Group of Hospitals and Colleges, my dear brother, being very ably assisted by his good wife, and Maria, they are more of a family to me, and very good memories about this institute and many other institutes. I think if one person has witnessed this institute growing, I think it's me at a different capacity. Since Agha Shabir Sahab, chairman of the organizing committee, and again Madam Maria, who worked with me in different colleges, very fresh memory. Many friends to be sitting off this stage, but as important as people sitting on the stage. If I start naming them, because you are all family to me, and I think I've seen so many familiar faces, because of paucity of time, please excuse me if I don't take everyone's name. Anyhow, it is always a pleasure to be here at Askar Said Medical College, because the way it is progressing and inculcating knowledge to our youngsters sitting there, I think it is remarkable, because extremely important in the healthcare to keep our students, training, faculty abreast with the modern knowledge. Medicine has changed, I think, much more about 200, what has changed in 200 years, it has changed more than that in the last 20 years. I think one glaring example is COVID-19, which very bad exposed us that how little we know about human mankind and its ailments. COVID-19 is a subject by itself, which I never studied when I was in undergraduate or postgraduate at all. And I never taught millions of my students qualified when I was, in different capacities at King Edward and Bal, and it's not same as these. It is my first university is after Zulfikar, it is called Shahid Zulfikar in Bhutto. Medical University. Just to make a correction, it's not named after his daughter, but the father himself, and I was chief executive of FAMES at that time for 4 years. I started that university, that is why that university is doing very close to my heart. I also started a medical college in federal government, the only one which is there, Federal Veterinary Medical College. So, since the medicine is changing so rapidly, it's extremely important to build up the capacity of ourselves as faculty members and translate the same to update our students, which are the future of our nation. I congratulate Farooq and Faria for starting this. I was just asking him which con it is. Sometimes it is family con, doctor's con, there is some conference abbreviation, so I'm sure they are going to name it very soon. Farooq con maybe, whatever, or whatever the name, but anyhow, it's a great start because this is a historical moment. This is the first conference, a multi-speciality. I was just going through the program, a very great program and great speakers delivering the talks. Already Faria told me that they had several workshops on very, very important subjects. Only thing I would suggest that since the logo of my previous university, UHS, is there, I will ask UHS to credit this so that the credit points can go to the speakers and also to people who are attending, especially the students, so they can put it on their CV that they have attended this conference, consisting of so many CM credits. So I'm sure it deserves at least 15 or 20 credits, but obviously you have to just apply online to UHS, and I'm sure that these credits are really awarded. So updating of the knowledge remains of paramount importance today. Since we want our students to practice medicine up to 2023 and beyond, medicine of 1990s. So that is why it's great thing. I always say that institutes is not just brick and mortar and beautiful auditorium. Institutes is all about having good tradition and making sure that those traditions are followed in letter and spirit. Once you follow those traditions and regularly improve those traditions, then the institutes just get all the strength. And if we have strong institutes, that will ultimately result into strong Pakistan. Unfortunately, in Pakistan, we are not following this pathway. What we are doing is we are just strengthening few personalities and not the institutes. I think unless we learn to strengthen our institutes, and I think today's start of this conference, inaugural session, marks that this institutes mean business and they are creating very good tradition, and I'm sure the next conference, the second conference that will be held under this prestigious institute will be much bigger and probably will be held in some other auditorium, because I'm sure, and that will give all the strength to this institute. So I congratulate everybody involved, especially our Isa, again, he's a very good friend, I believe. Punjab government will be all too glad to help. Also, I think Punjab government has started a very robust CME program in different specialties, and I think next time, inshallah, we should involve Punjab government as a stakeholder. So we sponsor people from all over Pakistan and abroad. We bring legends who are in UK, US, wherever they are working. we asked them to come over and exchange knowledge with us. And we sponsored them ourselves. This is recently I started. So, inshallah, next time, hopefully, we will be even much improved version of this conference. But nonetheless, this is a very, very good attempt, very good start, and as expected from the Medical College, because they hold their convocations very regularly, which is a very remarkable thing, and also because that's still academic piece, and this is the reason is that this is not being managed by an investor. This is managed by professionals, owned, run, managed by professionals who are from our profession, where they do understand the problems and they do know the solutions as well, and they implement them very quickly. So I'm very grateful to the organizing committee for asking me to come here and spend some time. It was always a pleasure and a treat for me to come to this institute. And once again, it has been a very immense pleasure being part of this festival. Thank you so much.
Our theme this year resonates deeply with the core mission of Akhtar Said Medical and Dental College. It reminds us that the quest for scientific discovery and medical innovation should always be guided by a fundamental principle, ensuring that every individual has access to the highest quality of health care. Moving forward, I'd like to introduce a very special guest of ours, a man with a distinguished career in the public sector as well as general administration. A career expanding over 30 years, in which impressively he served as Federal Secretary, Assistant Commissioner, and Commissioner as well. Holding distinctions as being a traveling scholar and a brilliant fellow, the CEO of the Punjab Healthcare Commission, and our next guest of honor today, Dr. Muhammad Saqib Aziz.
Honorable and distinguished Professor Dr. Javed Akhtar Sahab, Minister of Health, Dr. Farooq Sahab, the organizers, distinguished guests, professors, students, ladies and gentlemen, Assalamu alaikum. My name is Sakiti and I am currently working and serving as CEO of Punjab Healthcare Commission. And I believe that most of you would be familiar with our working and functioning. And those who are not familiar, I'll just narrate something about our working and functioning so that all who are sitting here are familiarized what we work. First of all, I am glad and pleased to be part of this annual scientific conference, and I am happy and really honored to be part of this annual conference. During today's session, I believe that you will be listening all the technical things regarding health for all. But for a layman, if somebody asks you what is health for all, the concept it emerged in 1970s, and it means basically universal health coverage, and it has certain themes. For example, access, quality, equity. So these are, and affordability, of course. So these are 3 or 4 main themes of health for all. And if you are familiar with the Millennium Development Goals and Sustainable Development Goals, the concept of health for all is very much embedded in the Sustainable Development Goals. And each government of the world was expected to make some efforts to reach out to its people for universal health coverage. So in Pakistan, if you remember the famous 18th Amendment, the health sector was provincialized, and earlier it was with the federal government, now it is provincial subject. And then, of course, recently the government has embarked upon the Universal Health Initiative forming cellular card to reach out public at the periphery. So these are some steps which government of Pakistan has taken. But coming back to what Punjab Healthcare Commission is doing, let me share with you that we started work after promulgation of our Act 2010, and we started working in 2012. And so far, we have been able to register more than 67,000 healthcare establishments in the Punjab, more than 67,000. And of course, that includes public, private, homeopaths, and PIPs. So every and each kind of healthcare establishment which is providing health services in the Punjab, we basically provide a very robust regulatory framework. And the first step is its registration. And then, of course, we conduct different inspections, and ultimately we grant license, regular license to that HEC. Apart from this, we are also mandated to hear complaints about maladministration and medical negligence. And so far, जब से बना है हमारा Healthcare Commission, we have received more than 4,000 complaints, and out of which only 300 which are currently pending, all are decided. And of course, it is a very challenging thing for the Commission also to adjudicate and decide such cases. Another mandate of ours is to take action against quackery, and I'm sure that is a very favorite subject of doctors. And it is usually we are questioned, and blame was also put on Punjab Healthcare Commission that you are oftenly you go after doctors and you do not take action against quacks. So let me share with you some figures which are verifiable, and so far, I mean, during the last 10 years, we have been able to see 34 or 36,000 quackery outlets in all over Punjab, and more than 34,000 quacks, they have left their profession, they have gone and they have started something else. So you can ask a question which is very pertinent, that whether you have been able to stop or control quackery. This is a very pertinent question. The answer is no. And there are many reasons. The issue of access, number one, which is also one of the pillars of health for all. Number two, socio-economic factors in our country. So these are some factors which favor, and of course our culture also, which favors which favor for quackery, which is still we not able to control. Before I wind up my talk, I have two messages. One message is for the seniors consultants who are sitting here, and one for the students. Sir, you being professors, consultants, or HODs, basic responsibility of efficiency or improvement of healthcare lies on your shoulders. You are the people who are responsible for making or developing a culture in a hospital. And what this culture is, the culture which I have understood as a doctor and as, of course, while working in Punjab Healthcare Commission, it squarely revolves around your conduct, your behavior, your attitudes, and medical ethics. You are the leader in your own capacity, whether you are in a ward, you are heading a ward, or wherever you are. You are leader and you must lead with example. Sir, बातें करने से we cannot become leaders. You have to lead others by example. So this is for the consultants and seniors who are sitting here. And of course, when we talk about behavior and conduct, it means proper counseling and to the patient so that they can make informed decisions. Our healthcare system in Pakistan, not only in Pakistan, but all over the world, is very heavily doctor-centric. Have you ever thought that how we can make it patient-centric? कैसे आपने इसको डॉक्टर-centric से patient-centric में लेके आना है? By changing the culture of your hospital, by changing your behavior and attitudes, and of course by following the medical ethics. So this was the message for the senior ones and the junior ones who are sitting upstairs, that don't find shortcuts in your life. Do not find shortcuts. I do not follow shortcuts. Things will come to you automatically. What you have to do is, and what is required of you, is hard work and commitment with your profession, and things will automatically come. In the end, I am thankful to Dr. Said Medical College and Farooq Sahab and everybody who's sitting here, organizers, for inviting me and giving me the opportunity to talk to you. Thank you very much.
Thank you all for your presence here today. We look forward to the invaluable insights and initiatives that will emerge from your collective efforts. This conference is more than just a gathering of experts. I'd like to invite one of the most knowledgeable people in this college right now, a man without whom none of this would be possible. Please join me in welcoming one of our most respected, honorable, and esteemed professors, Dr. Farooq Saeed Khan.
Bismillahirrahmanirrahim. I welcome Professor Javed Akram, the Health Minister, Dr. Sakir, the Chief Executive Officer of Punjab Healthcare Commission, delegates and students on this symposium, oblique scientific conference of Dr. Said Medical and Dental College. The purpose of this symposium is to highlight the importance of evidence-based medicine. The symposium is comprised of 3 scientific sessions, including medicine, surgery, and other care. In addition to these 3 scientific sessions, Dr. Said Medical and Dental College hosted 4 pre-conference workshops, where hundreds of doctors and students of final year all over Lahore, particularly King Edward Medical University, took a great interest and improved their clinical and procedural skills. All these scientific papers being presented at this conference in respective scientific session are based on the original high quality clinical data retrieved from the affiliated hospital. ये सारा जो पेपर है सर, ये हमारे अपने हॉस्पिटल के रिसर्च पेपर का मानसिक डाटा सारा किया।
Most of these papers have been published in international and national journals, including Journal of Dr. Said Medical and Dental College. And in addition to scientific session, we have a state-of-art lectures by eminent professors who have taken time out of their leisure. Moreover, we have made it compulsory for our junior doctors, including house officers, postgraduate trainees, these scientific papers and posters in order to promote and culture of evidence-based medicine. There are almost more than 50 posters, out of which 25 from King Edward Medical University and other universities, who are participating in this conference. All relevant stakeholders should promote such activities in order to uplift the standards of medical education so that they can keep pace with the international community. A system of continuous appraisal based upon completion of CMER, acquisition of clinical skills, and adoption of innovative medical teaching techniques and research methodologies should be mandatory for all doctors and should be inculcated in the ENBC criteria for promotion of faculty members. ये तो एक शॉर्ट सी इंट्रोडक्शन थी सर इस सिम्पोजियम के लिए। मैंने एक रिक्वेस्ट करनी थी और एक प्रपोजल देना था सीओ हेल्थ केयर कमीशन का। हमारे अल्हम्दुलिल्लाह ऑलमोस्ट 6 हॉस्पिटल है सर पंजाब में, और हमने अपना जो स्टाफ है उसके लिए कोर्सेज हेल्थ केयर कमीशन का जो MSCS है, मिनिमम स्टैंडर्ड है, उसके लिए हम कोर्सेज भी कराते हैं और उनका टेस्ट होते हैं, और अगर वो टेस्ट में पास होते हैं तो उनकी एनुअल इंक्रीमेंट लगती है जितने मेडिकल होते हैं, उसके बगैर हम नहीं करते। और डॉक्टर साबर ने बहुत मेहनत की हुई है इस पर राइट फ्रॉम द बिगिनिंग, और अल्हम्दुलिल्लाह हमारे सारे हॉस्पिटल फर्स्ट टाइम में लेसन हैं। कभी दोबारा सेकंड इंस्पेक्शन की हमें जरूरत नहीं पड़ी बिकॉज हमने एक सिस्टम डेवलप कर लिया। यहाँ पे मैं आपसे ये रिक्वेस्ट करूँगा कि वन स्टेप मोर, बिकॉज वी आर ऑल्सो इन द मेडिकल एजुकेशन। ये मेडिकल जो ग्रेजुएट्स हैं मेरे, मैं इनको हमेशा कहता हूँ कि आप एडमिनिस्ट्रेटिव साइंस पे आए। ज़्यादा लोगों का ख्वाहिश होती है कि हम क्लिनिकल साइंस पे जाएँ, स्पेशलाइज करें, हालांकि इस फील्ड में बहुत स्कोप आगे का। हमारे जो हॉस्पिटल्स हैं, जितने पब्लिक एंड प्राइवेट सेक्टर में, अगर हमें कोई एडमिनिस्ट्रेशन का बंदा ढूंढना होता है तो बहुत सी प्रॉब्लम होती है, जिसको वो उसको पता ही नहीं है MSCS का। तो हमारे पास पर सीनियर लोग हैं, इसलिए पब्लिक हॉस्पिटल्स को प्रॉब्लम हो रही है फॉर गेटिंग LSMs। इसके लिए हम सब एक डिप्लोमा शुरू करने जा रहे हैं विद योर कोऑपरेशन, जिसमें मैं आपसे ये रिक्वेस्ट करूँगा कि आपके जो विंग्स हैं, जो एक ट्रेनिंग विंग्स है और एक इंस्पेक्शन विंग्स, उनके भी ट्रेनर्स को हम शामिल करेंगे, अपने लोगों को भी शामिल करके हम कोई 6 मंथ्स का एक डिप्लोमा शुरू करने जा रहे हैं। और UHS में मैंने वाइस चांसलर से बात की, वो कहते हैं कि आप सारा इसका दें, POS वगैरह, सिलेबस वगैरह और सारा काम आपको इसको ऑथेंटिकेट कर देंगे। तो ये हम चाहेंगे कि हम आगे जाकर शुरू करें ताकि हम हेल्थ केयर कमीशन को असिस्ट कर सकें। बाकी मैं वंस अगेन आई एम थैंकफुल टू प्रोफेसर जावेद अकरम। ये 2007 में जब कॉलेज खुला था, बल्कि कॉलेज खुलने से पहले जावेद साहब से मैंने रिक्वेस्ट की तो ये आए, इन्होंने देखा EMDC की इंस्पेक्शन में भी इन्होंने हमें बताया कि यार यहाँ पे ये कर दो, ये कर दो। तो इनका माशाल्लाह बहुत एक्सपीरियंस था और हमारे एनुअल फंक्शंस में भी आते रहे, कॉन्वोकेशंस में भी आते रहे। तो मैं डॉक्टर साकिब का भी बहुत शुक्रिया करता हूँ और बाकी सारे डेलीगेट्स और फैकल्टी जो मौजूद है। इंशाल्लाह इनॉग्रल सेशन इख्तिताम की तरफ जा रहे हैं, इस वक्त हमारा प्लान है कि फिर हम जो गेस्ट आए हुए हैं पर्टिकुलरली साकिब साहब और जावेद साहब इनको सी ऑफ करेंगे और आपका फर्स्ट साइंटिफिक सेशन स्टार्ट हो जाएगा। थैंक यू वेरी मच।
We hope to foster an environment where new ideas are born, where partnerships are forged, and where solutions to the healthcare challenges of our time are conceived. Thank you all for your presence here today. Finally, I would like to request our principal, Professor Maliha Aslam, our chairman, Dr. Farooq Syed Khan, co-chairperson, Professor Dr. Fariha Farooq, and the chairman scientific committee, Professor Alva Shabir, to stand with me for the shield distribution to two important people. I would like to request the guest of honor for Dr. Javed Akram to come on stage to receive their shield. Now I would like to request Dr. Muhammad Saqib Aziz to receive their shield. Lastly, we would like to thank you for your precious time and your words of wisdom. We will start our next session shortly. I would like to request Dr. Mushtaba to please come on stage.
बिस्मिल्लाहिर्रहमानिर्रहीम। अल्लाहुम्मा सल्लि अला सय्यिदिना व मौलाना मुहम्मद व अला आलिहि व सहबिहि व बारिक व सल्लिम। I think everybody knows me here. So I can apply for elections now. So I'm a student of medicine. Those who don't know me, I'm a student of medicine working as a professor of medicine in Medical Unit 2. I intentionally use the word student because all of us are students. We will remain students till we are alive. Medicine is actually an ever-learning process, and for this we have organized this medical conference, and I'm going to host to moderate this prestigious session of medicine and life. So medicine is actually an ever-changing thing, and for this session, first I would like to invite a panel of experts. First of all, I will request a very senior professor, my teacher, teacher of teachers, Professor Zafar Iqbal Chaudhary, to please come up and chair this panel of experts. Next, I am going to call three professors of medicine, namely Professor Rizwan Zafar, who is HOD of Medical Unit 2, Professor Sabina Fida, who is a very good addition in Medical Unit 2, Professor Muhammad Lateef, who is a professor of medicine in Medical Unit 1. And last but not the least, I am going to invite a very senior professor who lives in our hearts, an educationist, fellow of College of Physicians and Surgeons, and fellow of Royal College of Physicians in London. He was professor and HOD of medicine in King Edward Medical University. He is senior vice president of Pakistan Society of Internal Medicine. He was our HOD as well. Professor Tariq Wasim, please come on the stage. बच्चों थोड़ी सी अटेंशन चाहिए कंसिडर करो कि ये मेरा लेक्चर है सारे चुप हो जाइए so anyway I'm going to start. We have got two components of this session. We have got first component in which we have got two state-of-the-art lectures by two very senior professors, and in the second component we are going to have 5 research papers to be presented by our junior colleagues. So the first paper is first session is a very interesting session on a very important disease which is known as fatty liver disease. It's known as non-alcoholic fatty liver disease, but it's no more non-alcoholic fatty liver disease. It's MEFID now, metabolic dysfunction associated fatty liver disease, because it has got strong connection with metabolic syndrome. And it's becoming a new pandemic these days. For this, I'm going to invite another very senior professor who is a graduate of Nishtar Medical College, Multan. He is a fellow of College of Physicians and Surgeons, Pakistan, and member of Royal College of Physicians, United Kingdom. He was trained in United Kingdom in a university hospital at Sheffield. He worked at King Edward Medical University and the Lawa and Bal Medical College in different capacities. Currently, he is working as the Dean and HOD of Medicine at Gulab Devi Hospital, Lahore. He has got special interest in poetry, literature and calligraphy. He is an intellectual, by the way. He has got 2 books of poetry to his credit. So I'm going to call a poet, so I thought I'll call him in a poetic way. So sir, आपके लिए हमारी आँख जरा मुख्तलिफ है लोगों से, जो देखते हैं वही आपको दिखाते हैं। हम ऐसे लोग गवाओ ना है ज़मीन वालों, हम ऐसे लोग कहाँ बार बार आते हैं। प्रोफेसर महमूद नासिर मलिक।
Bismillahirrahmanirrahim. Thank you very much for this kind introduction, and thanks everybody here in the hall. It's a very, very important. I was here in the operation of this college here. Professor Is Mohammed was your principal, and so the calligraphy you can see is Bismillahirrahmanirrahim. This is my own creation. So we start from here, in the name of Allah, the most merciful. Now, going to, I said, Mahfal, Masjid, Jafal, so many things. So, what's in a name? They say you call a rose by any name, it remains a rose. But say if it is a tube rose, or is it a daffodil smelling of rose, then we have to rename it. And this is what has happened with non-alcoholic fatty liver disease. If I am a teetotaler and somebody says to me, you are having non-alcoholic fatty liver disease, how would I feel? So this is stigmatization. And this has led to the new term. So it started in 1980 from Mayo Clinic, Dr. Ludwig, 20 patients, and they were non-alcoholic. And biopsy showed steatosis. So he done non-alcoholic fatty liver disease. So from 1980 till now, we have been dealing with NAFLD. And now with metabolic syndrome and everything, we have come with a new term. metabolic dysfunction and static cardiac disease. So we'll be briefly having introduction to this. So this is Ludwig and then 1983. वहाँ आई नहीं है, वो भी नहीं आया, वो आया बिस्मिल्लाह वाला नहीं आया। इसमें आपको कुछ और दे मिस हो रहा है। So from non-alcoholic fatty liver disease, it has gone so many names, right from metabolic acidic steatohepatitis disease, metabolic dysfunction acidic fatty liver disease, and now a newer term is emerging, though it's part of that is GAFFED, genetic acidic fatty liver disease. So certain genes which can lead to a fatty liver disease, that is a total different entity. So what fat does? We all eat fat. Fat goes to the liver. And do you need a history or something? So fat is a thing which would lead to inflammation, wherever it is. So right from steatosis, the ballooning, which is steatosis. Then we have done non-alcoholic steatohepatitis. Steatosis, it's a ballooning of the cells with the fat and then inflammatory response. That was NASH, non-alcoholic steatohepatitis. But if we say NAFPERS, then we have to say only steatohepatitis, not NASH, non-alcoholic steatohepatitis. But once this hepatitis sets in, then we go to the fibrosis, which is mainly perivenular and perisinusitis. And once fibrosis set in, certain of these people, they can go on to cirrhosis of the liver. And from cirrhosis, we all know it can lead to other problems like hepatocellular carcinoma. Then we have got association of diseases with hepatitis B, C, Wilson's disease, other liver diseases. So initially NAFLD, we had to exclude all these things. No alcohol. Even now the alcohol limit is 18 units for males and 9 units for females. This is allowed even for non-alcoholic fatty liver disease. Because in the Western Hemisphere, you know, everybody is social drinker. So this is the limit, 18 and 9. And then we've incorporated this metabolic syndrome into this method. Metabolic dysfunction associated fatty liver disease. So hallmark is obesity. But certain people, they are not obese. They are very lean and they still have got fatty liver disease. So that is a different thing. The lean people with less BMI and they are going to having this fatty liver disease. Now how we come to know? That would be another part which we are going to discuss. Can we have this slide? Okay, so this would encompass what is metabolic acidic fatty liver disease, what is the etiopathogenesis, what are the signs and symptoms, what is the treatment, and what are newer aspects of the treatment. Because there are recently, up till 2019, there was 190 drugs which were being tried for fatty liver disease. So you can see the spectrum of this disease and the scope of medicinal treatment is there. So, we are here. So we are here. Isn't it beautiful? This is my own creation. So from the Allah, मैंने जब लिखना सीखा था पहले तेरा नाम लिखा. So this is what it is. So now we go on to the fighting liberties. What's in a name? I've said what is in a name. So name is something because name is your recognition. So name is recognition of NAFLD, MASLD, MAFLD and now capital genetic associated fatty liver disease. So here we go on to the Ludwig. I've already told you. The medicine language matters and can I have a what's the mic? Okay. Okay, so disease can have a profound impact on the pregnant and families. Chronic alcoholic liver disease. Can we call anybody here alcoholic liver disease because that would be a stigmatic. So this is now MA-friendly and encompasses everything inclusive, and I'm coming to it later. So now this is the beta steatosis in adults detected either by imaging techniques, blood markers, and either the scoring system, because everybody, we can't go in and do a little box. So overweight and obese, they are called NAFLD. This is the spectrum, the BMI. The BMI is, okay, so BMI of 25 in Caucasians, 23 in Asians. Okay, fine. So we have got a diabetes mellitus that goes into this diabetes mellitus, and at least two of these metabolic risk factors. So I can come here. This is important, right? I will be skipping a few slides and I'll be standing on a few slides to describe few things. So here, the base circumference 1 or 2 by 8 in population. Anyways, okay, fine. The blood pressure, this is all metabolic syndrome. Blood pressure 135, or even if a patient is on treatment. And plasma triglyceride 150, HDL less than 40, average Pakistani is 38, I can tell you. And 15 females, pre-diabetes, that is 100 to 125 of plasma glucose, not blood glucose. And 2 hours, 140 to 199, and HOMA model resistance score to 2.5. Recent recommendation, the CRP has gone out of this, but CRP was initially included, but objection was for Middle East and North Africa consensus, because everybody has got no facility for high sensitivity activity, so this was excluded from the definition. Now, it's an epidemic of the new millennium, we know it. All obese, even child obesity is going to lead us to these problems, because this is not a simple disease. It can go to fibrosis, cirrhosis, and hepatocellular carcinoma. Though it would take time to develop, say, 10, 20 years, but still, in the down line, we can have these problems. So, a new consequence of obesity syndrome, spectrum of condition characterized by macrovesicular steatosis in the absence of significant alcohol use. And I've told you the units before. It includes histological pattern, simple steatosis, which is without inflammation. And once inflammation set in, we call it steatohepatitis, previously called NASH. So still now the variations they intermingle. So steatohepatitis with inflammation, fibrosis, then cirrhosis. So we can have a patient who is not in the beginning, he has developed cirrhosis, and we now never know what it was. So many people with cryptogenic cirrhosis, they were basically fatty liver failure disease. And last year in the USA, the transplant due to alcoholic liver disease and fatty liver disease have surpassed those with alcoholic liver disease. So it's a big crisis in USA. Now, this is normal level here. We have got this steatosis with all these vesicles. We've got vesicles and we've got infiltrate. So once inflammation sets in, then probably this is the spot where we can deal it. Once it goes into fibrosis, though there are certain drugs which can reverse the fibrosis, not to that extent, but still they can do it. And then obviously this is a macronodular liver, cirrhotic liver, shunted liver, and with all its consequences of hepatic encephalopathy and dyslipidemia. Okay, so estimated prevalence is up to 25% of the population all over the world. And Western adults 20 to 30 with 2 to 3% having steatohepatitis. And in cirrhosis, 80% of these people, and while NASH is seen in 9 to 30%. So this is where inflammation would set in, presents 3% of these children, and most common of all liver disorders and frequent cause of chronic liver disease. So if I ask you the most prevalent liver disease, it's fatty liver disease, with all its consequences, obviously. Okay, so just a bird's eye view of the world. The maximum is Middle East, then we've got China, then we've got Africa, America, Africa, less food, less obesity, less fatty liver disease, and the Western world, 34. So this is just on looking at it, we know African continent is the best because they get less food, less obese. So some of them are, but obviously this is bird's eye view of the lakes. Okay. Now, ecological classification, one is primary FLD, one is secondary MFLD. So primary is when we have excluded other things, and secondary is when certain things are inclusive. Though in the modern definition, anybody having type 2 diabetes, mellitus, hypertension, other liver disorders, we include it. So there is no exclusion for MFLD. We fulfill those criteria. So going to the secondary, we have got severe weight loss, starvation, TPN, iatrogenic drugs, amidron, methotrexate, for example, tetracyclines, they can lead to this, refeeding syndrome, Graves syndrome, toxic exposure, lipid metabolism, beta lipopproteinemia. So these are the congenital sort of things. Okay, so this is a very important slide. I'll take a minute on it. On this hand, we have got non-MEFL and total NEFL. They are younger people, lower BMI, better metabolic profile, less fibrosis. On this end, we have got mainly MEFL, non-NEFL, and at risk of if intake of cruise, they are younger, predominantly males, better metabolic profile, but more severe fibrosis. So MEFL would be more severe fibrosis if their BMI is low, less fibrosis. And this is in between both. So we have got older people with high BMI, insulin resistance, metabolic comorbidities, and rise in the liver enzymes. Though rise in the liver enzyme is not definite criteria. So many people would be having fatty liver with no rise of the enzymes, and still all those consequences. So ALT rise is not inclusive, though we do it, obviously, but this is not the criteria. So this is another non-NEFL and non-MEFL. These are the people we are thin lean people who are not having any metabolic disorder,
And these are younger, they've got better metabolite and less new fibrosis. So this is what is one of the criteria is GAFR, the genetic associated fatty liver disease. Now, going to the various factors which can lead to the etiopathogenesis. So fat would lead to all inflammation. Circulating FFAs, fat is more, and hyponectin, insulin resistance, inflammation. This is a new coming up thing, gut biome. The gut bacteria, they can, obviously, this is the first step. From intestine, they go into the liver. So we've got two sets of gut biome. One is the obese variety, one is lean variety. So they behave different, but they cause and they go into the bile and everything. They cause inflammation. So bacteria, they go inside and they can lead to problems. So this is a huge research going on the role of microbiota in the gut and fatty liver disease. Once it goes in, we've got environment-related dietary fat, high caloric intake, and recently the fructose, high fructose content of the corn syrup in USA. Fine, I've left. Okay, fine. I've last 2 minutes. Okay, so this is how inflammation sets in, and with necroinflammation we go on to the fibrosis. Bacterial overgrowth, obesity gene, serum and liver iron, they are responsible for this. Leptin. So higher circulating level of leptin were associated with increased severity of NAFLD. Tumor necrosis factor A correlates with obesity derived from adipose tissue and reduces expression of CLAMP4, chemotexins, activation of stellate cells, and memory high inflammation. Variable clinical preservation, hepatomegaly, abdominal discomfort, liver enzyme normal in up to 75% of people, when it is usually modestly limited to 30 and maybe is 20, up to 1.5 and 2 times rise. MAFLD is diagnosis of exclusion. We exclude these things: alcoholic hepatitis, drug hepatitis, viral hepatitis, autoimmune, and metabolic. This is to be excluded. And once we think patient may have Wilson's or hemochromatosis, we go and do a therapy because they can have concomitant existence. All these tests we can do. We all know we can do all these tests. And going next, ultrasonography and elastography fibroscan. Fibroscan can tell us about the stiffness and level of fibrosis and steatosis. But hallmark is MR spectroscopy, which can clearly quantitate the fat. So it doesn't tell us about fibrosis and inflammation, but it quantifies, MR spectroscopy quantifies the level of fat. That's very, it looks like this on scan. So we can have MR spectroscopy, which would lead to this. So liver biopsy is indicated in two conditions: positive antibodies, accurate staging, mainly for research purpose. But nowadays, just for NAFLD, we don't do a liver biopsy. Certain indications are needed to lead to this. So, exclusion of other cause, distinguished steatosis from NASH, estimation of prognosis, determination of progression. This is what it is. So now you can clearly see here the steatosis and steatoinflammation. These are the inflammatory cells here, and this is those macrovesicular bodies. This is fibrosis setting in. Then our biomarkers were different because they are non-invasive biomarkers. Fibrotest, fibroscan, fibrospec, they can all be done. Now, just a minute about prognosis. 1.5% develop cirrhosis, 1% die of liver-related 10 to 12 years. 30% with NASH and fibrosis becomes cirrhotic within 5 to 10 years. Rate of 10%. were developed to HCC. This is important to know. This is not just fat, it will lead to inflammation and hepatocellular carcinoma. Okay, so cirrhotic resuscitation 15 and risk for HCC is 1 to 2%. Now the treatment. Hallmark of treatment is lifestyle modification in 7 to 10% weight reduction. If we can do it, there's so many trials, as I said, going on. Some have been proved, some are unproved, some are in stage 3 trials, some are in stage 4. I'll come to in a minute. So diet reduction, metformin. Metformin can lead to less fat, but it doesn't decrease fibrosis. Same is true about pioglitazones and others, but newer GLP-1 and GLP-1 and all, they are very important. Lipid lowering, vitamin E, 800 milligrams daily, especially in diabetic patients, can decrease fat. Ursodeoxycholic acid, ACE, provolone, and probiotics. Now, just a minute. अभी कितना टाइम है? 50. इसका बात करता हूँ. So obesity, overweight, type 2 metabolic dysfunction. So hallmark is mainstay of treatment is lifestyle modification. FRX agonist, ongoing study. PPAR agonist, ongoing. GLP-1, we know it. Ozempic, semaglutide, liraglutide. And TSH beta agonist, this is the newer thing coming in. And then obviously aim is to go for combination therapy because these are at different modalities and not one is able to control this fatty liver disease. Now this is a very busy slide, but I'll just take a minute here because this is the most important. This is dapagliflozin acting in the kidney. Newer are coming, which are even SCL2 and 1 inhibitor. Remdesivir, THR, this is in the trial phase. Liraglutide, as I have said, insulin resistance decreases. Lanifibranor, this is PPAR alpha and gamma, alpha and delta, sorry. So this is being tried. Then is Aramco, this is very good results. This was developed for gallstone disease. And then we have got OCA, obeticholic acid. Obeticholic acid, I'll take a minute on this and then we will finish. So Obetichol is a potent selective farneside axis receptor agonist. What does it do? It decreases liver fibrosis, bile hemostasis, portal hypertension, glucose metabolism, liver steatosis. Decreases inflammation, fibrogenesis, and fibrinolysis. So this is available, though it has been not approved by FDA for fatty liver disease, but it is approved for biliary cirrhosis and cholangitis. Though it has got also effect on other things. So this is indeterminate. We go to specialist reference and go for bariatric surgery and liver transplant. So we can stop, and if any questions, I'll take it later. Thank you so much.
Thank you very much, sir, for a very informative and detailed talk on non-alcoholic fatty liver disease or metabolic dysfunction associated fatty liver disease. So what you have learned from this presentation, my students, this is my lecture going on. So my question and my answer is that if you don't control fatty liver disease, this will be the most common cause of chronic liver disease, unfortunately. So we have to have lifestyle modification, we have to change ourselves, we have to improve our diet, we have to have exercise, and only then we will be able to prevent this unfortunate pandemic. So the next talk is on a very important topic, which is diabetes, and I know the most common cause of diabetes is type 2 diabetes. More than 89% of cases are of type 2 diabetes. And for this, I have invited a very senior faculty member, a very senior person who is a graduate of Ahmedabad Medical College. He is gold medalist and distinctions throughout his academic career. He He is a Fellow of College of Physicians, Pakistan, and Fellow of Royal College of Physicians, London. He worked at King Edward Medical University, Sims, Allama Iqbal Medical College as Professor of Medicine. Currently, he is the Professor and Dean of Medicine at Rashid Latif Medical and Dental College. He has special interest in medical teaching for undergraduate and postgraduate. He is founder of a channel which is Med Understand, an academic channel with full scale of lectures on all aspects of medicine. He is Senior Vice President of Pakistan Society of Internal Medicine, and he is a chapter editor in McMaster Textbook of Internal Medicine. He is a teacher of teachers. Please welcome Professor Azizur Rahman.
I was promised 20 minutes and I squeezed it to 20 minutes. I offered them to save the 10 minutes also by skipping my presentation. But they have sort of forced me to finish it in 10 minutes. So I have to actually run through the presentation. And the topic is innovation in the management of type 2 diabetes. So it is, my talk is restricted to the management in type 2 diabetes. There are many other innovations. So I think these are the different medications available. And the last three, these are the ones which I think are relatively new and we can talk about them. And I'm sure everyone sitting here are familiar with these things. GLP-1 receptor agonists, which are very, very popular drugs these days. We have a whole long list of these drugs. These are GLP-1 receptor agonists, and these are GLP-1 and GIP, and this is GLP-1, GAP, and glucagon. So these are new treatments, and in evidence we have these three available, and then the latest to come is the SGLT2, which I'll be shortly talking about them in more detail, and this is the list of dapagliflozin and multigliflozin. So the first innovation, I think, you know this system that whenever we eat, in anticipation of food coming, and our gut release incretins, and these incretins are GLP-1 and GIP. They have a wonderful effect on beta cells, alpha cell, brain, and stomach, but their action lasts seconds, 2 minutes, and it is destroyed by DPP-4. But in the body, there is no problem because as it is destroyed, more is released. But when it is used as therapeutic agent, it can't work because for that you will have to give it as an IV infusion. That, of course, is not possible for long-term management of diabetes. So scientists developed drugs which are very similar to GLP-1. They're called GLP-1 receptor agonists. Their effect is very much similar to our endogenous GLP, but that is not destroyed by DPP. So it has got extremely good upper side, potent A1C lowering effect, no hypoglycemia, and low weight. In fact, it helps to lose weight and proven cardiovascular safety and benefits, and there is renal safety also. The little downside, they are injectable. People do not want injections. They're expensive, and also there are some GAD side effects. Very occasionally they can cause pancreatitis. So to sum up, I think this slide is, I made it very simple. Profile of GLP-1 receptor agonists. They reduce your A1C, which is the aim of the treatment, and very effective. They are classified as one of the most potent drugs, and then they reduce cardiovascular disease. So that is additional advantage, and they reduce weight also. Many people with type 2 diabetes are overweight, and they do not cause hypo. So hypo is neutral. Every other thing they are better. So you know, these days, every new anti-diabetic drug has to undergo this called CVOT, cardiovascular outcome trial, and I can't go into the detail, but this was mandated because of some bad effects of some other drugs. So all GLP-1 one receptor agonist have undergone these trials. Leader was about liraglutide, Rewind about dulaglutide, Sustain about semaglutide, and all have passed this test. All are cardiovascular safe, not only safe, in fact they can extend some benefit over and above to glycemic control, so they get double yes. So that is why they are very popular and they have been included in the guidelines. This is the consensus statement of American Diabetes Association and European Association for Study of Diabetes, and they come right here. So according to the recommendation, after lifestyle changes in metformin, if somebody has increased risk of atherosclerotic cardiovascular disease, that patient should be given GLP-1 receptor agonist. The innovation number 2 is the DPP-4 inhibitors. And same thing, but GLP has got very, very short action. Scientists thought of developing DPP-4 inhibitors so that our own endogenous GLP stays in the system for longer. So they developed many drugs, they're called DPP-4 inhibitors. The main characteristics are, they're very well tolerated. The side effects are like just placebo, once or twice daily, and they perfectly with metformin. This is important because our first line treatment is metformin. DPP-4 inhibitors can be added and they pair very well with metformin. Hypoglycemia, low weight gain, cardiovascular safety, proven. And the downside only border section, they're not very, and they have, their effect is lost once beta cell goes away, which is a natural shift type like 2 diabetes, you know. So, to sum up the profile of DPP-4 inhibitors, HbA1c reduction, modest, cardiovascular disease, no risk, no benefits, at least neutral, and for weight, they're neutral, and no hypoglycemia. So, DPP-4 inhibitors can be seen as moderately effective glucose-lowering therapy with no hypoglycemia, no weight gain, and cardiovascular neutral, and very good addition to metformin. So they also underwent these trials. This is for PCOS, this was about sitagliptin, Vivid about vildagliptin, and other gliptins also. So they get yes because they are oxalate, they are cardiovascular safe, they do not increase any cardiovascular risk. This is particularly important because 80% of the morbidity and mortality related to type 2 diabetes is cardiovascular. So according to this, they were given this indication after metformin. If you want to add another drug, that should be DPP-4. I think it's one of the agents, DPP-4, because they're weight neutral and they do cause hypoglycemia and they're very, very useful drugs. So innovation number 3 is the development of SGLT2 inhibitors. I'm sure you know physiology. Our glucose is filtered into the glomerulus, all of it. But all of it is reabsorbed because it is very, very essential nutrient. We cannot live without glucose actually. And this glucose is reabsorbed, and scientists they thought of this blocking SGLT2 so that glucose is not reabsorbed, at least a part of it. So you know in diabetes this actually increased because more glucose is presented to nephron, more is filtered and more is reabsorbed. So by blocking SGLT2, we allow glucose to pass into the urine. So that would result in glycosuria. That would obviously result in reduction in blood glucose level, but there will be glycosuria. And glycosuria will also lead to some weight loss. So the main characteristic of this class of drug, potent A1C lowering effect, convenient once a day dosing, no hypos, modest weight loss also, pairs perfectly with metformin and favorable cardiovascular effects. Downside, they may cause polyuria and dehydration. Occasionally, very occasionally, they can precipitate euglycemic pKa and they can cause renal shutdown if given to a person who is already volume depleted. So, profile of SGLT2 in summary, they have very, very good HbA1c lowering effect and very good effect on cardiovascular disease and extremely useful effect on heart failure. So much so that heart failure, even without diabetes, is I think SGLT2 inhibitors are being used, and very, very surprising effect on CKD. In fact, when these drugs were being developed, it was clear that there would be actually increased risk of nephropathy because we are principally with the kidney, it was thought they might cause increased risk of nephropathy, but actually they protect kidneys, so even if there is some nephropathy being the process, they can reduce it. So they can help you to reduce weight and they do not cause hypoglycemia. So I think from every parameter, these drugs can be classified as very good drugs. So they also underwent this cardiovascular trial. Ampylect was actually a surprise, and empagliflozin showed there is a reduction in heart failure, reduction in heart failure related hospitalization, reduction in all-cause mortality, and similarly, declared with dapagliflozin, again very useful drug. So they also get, yes, I think after GLP-1 receptor agonist, SGLT2 receptor, they got double recommendation because they're not only cardiovascular neutral, they actually extend benefits over and above the benefits given to the good glycemic control. So according to this, because of this, they got applied in the recommendation after metformin, those patients who have kidney disease, even marker glomerulia, or reduction in GFR, or they have heart failure, either type, reduced ejection fraction or preserved ejection fraction, all can benefit from addition of SGLT2 inhibitors. So this is the treatment algorithm. The original algorithm is very, very complex, but I have made a simplified version. This is how you know about it. Lifestyle changes, metformin, atherosclerotic cardiovascular disease, GLP-1 receptor agonist, heart failure, CKD, and SGLT2 inhibitors. Then we move on. And this is the summary, I think I'm getting so. Summary is very simple. Think beyond glycemic control. Diabetes is not just hyperglycemia. We need to control glucose, but we must think beyond it. Move from glucose centricity to cardiocentricity. And if you have a patient with increased risk of atherosclerotic cardiovascular disease, after metformin, GLP-1 receptor agonist makes a great choice. If somebody has CKD and SGLT2 inhibitors are very, very good drug. And if somebody has got heart failure either type, I think SGLT2 inhibitors would be a great drug. So I'd like to conclude with this announcement. This lecture is available on my channel called MatterStand, and like this, many other lectures that you find, I think, I'm sure most undergraduate and postgraduate will find that. Thank you very much.
Thank you very much, sir, for taking his time. So we learned that there are new modalities of treatment in type 2 diabetes mellitus, namely the top of the tongue, inhibitors, and GLP-1 analogs, and most likely the future belongs to these drugs. So now we are going to start the second component of our session. This component has, research papers which are done by our faculty in our hospitals, and our junior colleagues are going to present these papers. These papers will be evaluated by an esteemed committee, and they are going to have prizes for that. So I would like to invite the award committee for the session of medicine and allied. I would like them to please come and sit on the judges' seat. Professor Ambareen Mumtaz, Professor of Gynecology, Professor Atif Chaudhary, Professor of Anesthesia, Professor Iram Manzoor, Professor of Community Medicine and HOD of Medical Education, Professor Nadeem Malik, Head of Peds Neurosurgery. So the judges are here. So we can start with the first paper. Chronic liver disease is a big problem, and we are going to face the patients of ascites every now and then. And what we have to do, we have to remove the fluid. We have to do abdominal paracentesis. And paracentesis, the fluid from the ascitic fluid is rich in proteins. So you have to replace this protein with albumin, which is a very costly drug. We are going to see a paper that whether plasma expander, especially Maxil is a replacement of human albumin in chronic liver disease. So I'm going to call Dr. Faiza Mukhtar, who is PGR R3 in Medical Unit 1, present your paper.
Most merciful and most beneficial. Assalamualaikum and welcome to everyone. My name is Dr. Faiza Mukhtar and I am the postgraduate president of Medicine Unit 1 Akshay State Trust Hospital, Lahore. Today I am going to present a study on behalf of Dr. Mohammed Lateef. So the topic of my presentation is human albumin for plasma expansion during. As you all know, ascites is a major complication of chronic liver disease. It is frequently refractory and a major cause of morbidity. Therapeutic aspiration is a beneficial mode of treatment, but followed by some hemodynamic abnormalities. Colloids are administered following the large volume paracentesis. After the presentation, you will be able to learn the background of treatment of refractory ascites, to know what is Maxil, understand the role of Maxil in large volume paracentesis in cirrhotic patients with dense ascites, to compare the efficacy of IV albumin and the Maxil during or hemodynamic changes during paracentesis or immediately after the and to remember the benefits of paracentesis with Maxil administration. Hemaxil or polyethylene is a colloid-containing gelatin with a molecular weight of 30,000 Dalton, iso-40 plasma, having viscosity and pH similar to plasma. With albumin, in prevention of hemodynamic changes, periparacentesis or immediately after paracentesis. Coming on to the patients and methods study, it is a comparative study. The patients with dense ascites were divided into two groups. Group A was given albumin while Group B was given Hemaxil. 25 patients were enrolled in each group. Inclusion criteria for a study were cirrhosis with dense ascites proved clinically and by ultrasound, patients with a platelet count of more than 40,000 per microliter, patients with prothrombin time less than 4 seconds per long, serum creatinine of less than 3 mg per deciliter, and serum bilirubin of less than 10 mg per deciliter. We excluded all the patients with clinical laboratory and sonographic evidence of hepatocellular carcinoma. In hepatic subloperative regression, recent GIP, and we also excluded patients with spontaneous bacterial paracentesis. A day-before procedure, all basic tests were performed and were repeated after 6 days. GFR and plasma osmolarity were calculated. The procedure was performed in a fasting state, followed by early infusion of the Maxil or albumin in a dose of 6 grams per liter and 125 ml per liter of cytic glucose in blue, respectively. Mean arterial pressure and heart rate was measured both before and after the procedure. This table shows the demographic parameters which we studied in both groups of patients. It involves age, gender, and sex. While this table shows some clinical parameters which we observed after the procedure, this table shows some lab parameters which we studied in our presentation. This table shows the parameters which were observed in both groups of patients. There are some important parameters which we studied. It includes RFTs, serum sodium, plasma osmolarity, GFR, and mean arterial pressure. There were no significant differences between these parameters both before and after the procedure, and they have a mean value, significant mean value of So, post-erotic ascites leads to increased intra-abdominal pressure, increased portal release pressure. Therefore, it increases the portal systemic collateral pressure and ultimately increases risk of varices. Since effective ascites lead to liver transplantation, in the middle period, large volume replacement, large volume therapeutic paracentesis or lois with colloid replacement is only available in non-curative options. However, small volume paracentesis of 750 ml with hemoglobin has a positive hemodynamic influences such as increases cardiac output, decreased plasma resistance, therefore decreases portal pressure and varices. The hemodynamic adverse events which were observed in a period of 48 hours to 6 days after the procedure were prevented with plasma volume expansion with hepatocytic. A slight fall in sodium concentration and integrated serum osmolarity was noticed, but it was asymptomatic. A mild reduction in plasma urea and radical sedation provided evidence of improved GFR and renal function. The complications like moderate renal failure, hepatic encephalopathy, gastrointestinal bleeding, and bacterial peritonitis were recovered post-paracentesis. In short, large volume paracentesis followed by RV colloid as a plasma expander to prevent hemodynamic disturbances is very safe and effective procedure, except for a mild asymptomatic fall in mean arterial pressure. So, after this study, we concluded that the maxim is equally effective to albumin in paracentesis of tense ascites. It is safe, economical, and has equal efficacy to albumin. If you have any questions, you can ask. Thank you.
Thank you very much, Dr. Faiza. We are already using Hemaxin in our wards for abdominal paracentesis. We will have question and answer session at the end of all those talks. The next topic is very interesting. We know that typhoid fever and enteric fever is very common in our country, and because of misuse of antibiotics, we are having multi-drug resistant typhoid fever and extensively drug resistant typhoid fever. So this is a very interesting study done by one of our colleagues in our hospital, and this is going to be presented by one of our brilliant HOs, Dr. Zulfi Shah Muzammil.
Assalamualaikum everyone. I am Dr. Zulfi Shah Muzammil will be presenting Medicine Unit 2, Farooq Hospital, Westwood. No one has forgotten how in 1885, foul water had ignited an outbreak of cholera and typhoid that killed almost 10% of city's population. And today, after hundreds of years, we are still experiencing these outbreaks. What an irony. The title of my research is Clinical Perspectives of Multiple and Extensively Drug-Resistant Typhoid, result from a tertiary care hospital from Pakistan. It was published in Journal of Infection in Developing Countries. The authors are Dr. Samina Fida from Department of Medicine, Akhtar Saeed Medical College and Farooq Hospital, Westwood Branch, Dr. Hala Mansoor, Dr. Sabah Saab, Dr. Javed Ibad, and Dr. Arif Bayum Khan, Department of Medicine, CMH, Lahore. Let's come to the introduction. Typhoid fever is caused by Salmonella typhi and paratyphi. It remains a problem in developing countries, including Pakistan. The emergence of multi-drug resistance and, since 2016, extensively drug resistance cases is a continuous challenge for healthcare workers. This strain remains resistant to standard first-line and second-line agents used for the treatment of enteric fever, including fluoroquinolones, and it is only sensitive to macrolides and carbapenems. CDC, the Centers for Disease Control and Prevention, has issued a warning to travelers to Pakistan to take extra precautions because the same strain of bacteria has been isolated from the travelers in UK and US returning from Pakistan. The higher burden of disease in lower income countries is associated with poor sanitation, less food hygiene, and poor vaccination, whereas providing good sanitation and vaccination has decreased the cases in the developed world over the number of years. Resistance is increasing day by day, and we need to know the reasons, effects, solutions, and preventive strategies more than before. The methodology. We studied 52 confirmed cases of typhoid during 2019. Detailed clinical features, complications, and their lab findings were studied. Typhoid culture and sensitivity were recorded, and patients were treated accordingly. Patients were asked about risk factors to aim at informing prevention. The result 52. The culture positive for Salmonella type 4% and Salmonella paratype were 9.6%. The non-resistant cases were 7.7%, MDR were 21.2%, and XDR was 71.2%. One case was even resistant to azithromycin. Nausea, vomiting, abdominal pain was present in 23% of the cases. 17.3% showed abdominal distension, 15.4% abdominal tenderness, hepatomegaly was present in 19.2%, and splenomegaly in 42.3% of the cases. 12 to 26% of the cases presented with prolonged fever, with GI symptoms, toxemia, and liver function abnormalities. 58% showed ultrasound abnormalities. GI complications were present in 19%, and GI complications were the main finding in our patients. Between resistant and non-resistant cases, there was no significant difference found in clinical findings and complications. Only 23 to 27% of the patients were aware of typhoid prevention and vaccination measures. Here is a bar chart showing resistant in typhoid. Maximum shown in meropenem and azithromycin, and maximum resistance, as you can see, is observed by these green bars in ceftriaxone, ciprofloxacin, chloramphenicol, and cotrimoxazole. An ominous and profoundly concerning solution arises here, where we discovered a strain even resistant to azithromycin, which is the only treatment available for XDR typhoid. Here's a chart showing about the percentages of non-resistant cases, which were 7.7%, MDR, which were 21.2%, and XDR, which was 71.2%. Now we come to the conclusion. The increasing prevalence of resistance and higher degree of complications seen in typhoid fever raises the concern further about prevention and effective infection management in the community as well as the clinical settings. Extensively resistant enteric fever is one of the biggest challenges in endemic areas like Pakistan, and it is not still under full control. Needs more serious attention for prevention, control on the spread of disease, and judicial use of antibiotics. Finding a isolate, even resistant to azithromycin, is of great concern. And as the antimicrobial option for XDR typhoid are already limited, although we did not find any statistically difference in clinical findings and complications between both resistant and non-resistant cases. But typhoid complications overall are increasing in proportion and can bring serious consequences in future. Public awareness on prevention and vaccination is still not satisfactory, and more education programs are needed to sort this issue out. War is not a danger. War is a disease, and let's unite and fight against it. In the end, I would like my presentation to be ended with a message for you all. Prevention is better than cure. Thank you so much.
Very nicely presented, Lucia. Typhoid is not the only disease. As we saw that we have MDR and XDR typhoid fever, we have got problems in the tracheal secretions as well. We have got problems with the patients who are admitted to the medical ICU, and they have got pneumonia, and their tracheal secretions have got a lot of bugs, and the antibiotics are resistant to these drugs. So on a very important topic of tracheal secretions, sensitivity, and antibiotics, I'm going to call our medical officer of medical ICU, Dr. Jawhar Raza, to please come up and present this case.
Assalamu alaikum and good morning, everyone.
unit is bacterial isolates and their antimicrobial susceptibility pattern from tracheal secretions and sputum of admitted and outdoor patients. This study was conducted in Farooq Hospital and Dr. Said Trust Hospital by Dr. Umair Farooq and the leading pathologist Dr. Nila and Dr. Asim Mumtaz. Thanks to them. So, in the introduction of this presentation, we should first consider or define what are tracheobronchial secretions. These secretions are produced by goblet cells and mucus glands, and they humidify the inspired air and prevents everyone from infection. About infection, we have to differentiate first community-acquired pneumonia and hospital-acquired pneumonia. Community-acquired pneumonia is defined as any infection in a patient that develops outside of a hospital setting and patient had no history of recent hospitalization. And hospital-acquired pneumonia, which is, you can also say that it is a nosocomial infection, is infection that develops within 48 hours of hospitalization or after 48 hours of hospitalization. And talking about this hospital-acquired pneumonia, we have some major definition here, also known as ventilator-associated pneumonia. We can define ventilator-associated pneumonia as after 48 hours of invasive mechanical ventilation. Why did I introduce ventilator-associated pneumonia? Because in our ICUs, patients are mostly on mechanical ventilation and we come across different isolates from their secretions. So, to diagnose ventilator-associated pneumonia, we have three methods to isolate the organisms. Is bronchoalveolar lavage, which should be done by bronchoscopy. Second is lung biopsy, can only be done by a surgeon. And the third is the exist, which are tracheal secretions. And tracheal secretion can be taken by any paramedic staff or medical officer or respiratory therapist. That is why we chose this one. Over to the next slide, we have the study methods and materials. This is a descriptive type of study and the time duration falls from 1st August 2022 to 31st December 2022. And the time of sampling, as I described earlier, it was tracheal S58. The inclusion criteria of our study was all the patients which we received in our indoor and outdoor departments with pneumonias or lower respiratory tract infection. And the exclusion criteria, we excluded all the patients with except bacterial infections or bacterial pneumonias like fungal or parasitic infections or the patients who were immunocompromised. Now coming to the results, we had total 126 participants, out of which 69 were males and 57 were females. And we used tracheal secretion as well as sputum. Sputum is a type of specimen which could only be cuffed and it can only be done in patients who are awake and oriented and they can have a cuff reflex. While the patients who are on mechanical ventilation, they cannot cuff, and so we have to do a tracheal deep aspiration from them. So the mean age study participants of our study was 59.65 plus minus 20.36, and as we had more patients in adult group having hospital-acquired pneumonia, mean age group of our study fell in that age group. This is a very detailed slide, but I want to make some couple of most impressions out of it. As you can see in the middle of the table, here, we have two categories here and their percentages. One is from outdoor patients and the second is from admitted patients. The percentage from the outdoor patient who had no growth after 24 hours of culture is 46 total number was 46, and out of them, 4 were from outdoor and 42 from indoor. The most common isolated organism from our cultures was Klebsiella pneumonia, and the least common was Proteus species. And the only gram-positive organism was Staph aureus. So, most of the organisms like Klebsiella, all of them are mostly gram-negative rods. So why not gram-positive? It's because negative organisms have cell wall in addition to cell membrane, which is only present in gram-positive bacteria. In their cell wall, they have genes that encode for continuous mutation. That is why we have mostly gram-negative rods. Coming to the isolates and their sensitivity to antimicrobials, we have a very good, we have a very important message here that pig cycling was the only antimicrobial to which all the organisms were susceptible. And Proteus, our Citrobacter, was the only organism which was not susceptible to antibiotic, and it is a worrisome trend. So, to summarize my research here, we have concluded that Klebsiella species was the most frequent isolated species of gram-negative rods in fecal secretion and sputum specimens. Moreover, pig cycling is a highly effective gram-negative rods in vitro. However, you should be careful in patients with renal impairment because it is a renally secreted drug. Thank you so much.
Thank you, Johar. So we know that gram-negative rods are the most common bacterial infection in our ICU patients, like all nosocomial infections in the world. The next topic is on melasma. You know, melasma is a disfiguring disease, especially for females. So there are so many modalities of treatment for melasma, and sometimes it becomes very difficult to treat melasma. So we are going to see a new paper and a newer drug, and let's see what's the role of this drug in the treatment of melasma. So this is going to be presented by Dr. Zarmeen Mubashir, who is the House Officer in Dermatology. Dr. Zarmeen.
Assalamu alaikum everyone. I'm Dr. Zarmeen, working as a house officer in Akhtar Said Trust Hospital from Dermatology Department. The topic I'm going to present is the role of oral tranexamic acid in treating the patients of melasma in a charity hospital of Lahore. First of all, let me give you a very brief introduction about tranexamic acid and melasma. Tranexamic acid is a plasma inhibitor derivative of amino acid lysine. It acts by competitively inhibiting its plasminogen activator through reversible interactions with lysine binding sites, and it blocks the interaction between melanocytes and keratinocytes. Now, how to use tranexamic acid in melasma? It can be given orally or topically, and it decreases and reverses the melasma-related dermal changes like reduction of redness and number of vessels. Melasma is a very common disorder that is most commonly found in females as compared to the males in only 10% of the cases. It is a pigmentary disorder that consists of macules and patches of light to dark brown color which involves areas of the face and neck. Causes of melasma include sun exposure, genetic predisposition, pregnancy, use of oral contraceptive pills, thyroid disorders, and certain drugs. The materials and methods used in my study were descriptive cross-sectional study, and 70 patients of melasma were enrolled in this study. Study was performed in the Department of Dermatology, Akhtar Said Trust Hospital, and the time duration was from April to December 2019. Inclusion criteria was male and female patients greater than 18 years of age, and it was done after taking the consent of ethical committee and patients, and there was no conflict of interest. Patients with moderate to severe melasma were enrolled. Patients greater than 18 years of age having chronic medical disorders such as diastasis, heart disease, hypertension were excluded from the study. Pregnant and lactating females and females with menstrual irregularities and patients on anticoagulant and OCTs were also excluded from the study. Now the method. 250 milligram of oral tranexamic acid was given to the patients in DD for 3 months along with a very broad spectrum topical sunscreen. Follow-up was done on monthly basis 2 months after stopping the treatment. Photographs were taken at first visit and MASI score, which is the Melasma Area Severity Index score, was done at the start and after the 3 months of treatment. Side effects were also noted down, and for the patient satisfaction, evaluation results were rated as excellent, good, fair, poor, and no improvement. Results were recorded and analyzed using the SPSS version 11. Now moving on towards the results. Out of total 70 patients who were enrolled in this study, 44 were females and 26 were males. Mean age was 30 years and the duration of melasma ranged from 3 months to 12 years. Regarding the type of melasma, the epidermal type was the commonest type and it was reported to be 71.4%. There was a significant decrease in the MASI score from baseline at the end of the 12 weeks mean. 25 patients showed good result, 22 had fair, 16 had poor, and 70 showed excellent response to the oral tranexamic. No serious side effects were reported. No reversal of melasma was recorded at 2 months after stopping the treatment. Here you can see some demographic variables. Gender distribution and the pattern of melasma was male was 28%, mixed was seen 45.7%, centrofacial 11.4%, and mandibular region was seen in 2.9% cases. Here is the MASI scoring at 0 weeks at 12 weeks. The score was reported at 18.5 at the start of the study, and at the 12 weeks it was 15.1 and the p-value was found to be 0.002. Here you can see the graph of patient satisfaction. This is the pictorial representation at the start of the treatment and after the 12 weeks of treatment. Now moving towards the conclusion. The conclusion drawn from my study was that oral tranexamic acid can be used as an alternative treatment of melasma, or it can be given as an adjunct to other treatments already being used in this treatment. Here are the references used for the study. Thank you very much.
Very good presentation, Dr. Jameen. So what I have learned from this research paper, there is something called MASI. MASI index. It's not MASI at home, it's Melasma Area and Severity Index. So the last talk of today, you know, COVID-19 was a pandemic and it created a lot of problems, and we have seen that unfortunately young men and women have committed suicide during quarantine. So on this very important psychological topic of COVID-19, I'm going to invite Ashar bin Dawood, who is a final year student, to come and present his paper.
Assalamu alaikum and good morning to all of you. First of all, I thank all of you for sparing your valuable time for the scientific symposium. My name is Ashar bin Dawood and I am a student of final year MBBS in this esteemed college. Starting with the name of Allah, who is the most beneficent and the most merciful. As you all can see, the topic of my presentation is psychosocial changes and coping strategies in home quarantine nursing students of Pakistan during COVID-19 pandemic. So in this presentation, you will find introduction, methodology, results and discussion, and finally the conclusion. So starting with the introduction. World Health Organization declared coronavirus disease a pandemic on March 11, 2020, which affected 213 countries worldwide. And Pakistan was one of the most affected countries with a large number of cases and high mortality rate. Government of Pakistan followed the advice of WHO and soon quarantine and isolation centers were established. Another step taken by the government of Pakistan was closure of the institutions, which was extended from 13th March to 15th September, extending for more than 6 months of home quarantine for all the students. Effects of home quarantine. Home quarantine during this pandemic affected people at large, causing multiple psychological and social implications. Social distancing has increased the feeling of loneliness among the youth worldwide. University students being home quarantined for more than 6 months have shown to develop insomnia, anxiety and depression. Worldwide impact. Undoubtedly, COVID-19 affected students worldwide. So they have used multiple coping strategies to combat the COVID-19 stress. Most of the students are involved in excessive use of electronic devices for social media networking and for online academics, which has increased their screen time up to 6-fold, which is considered a risk factor for depression. Some students reported indulging themselves in physical activity worldwide, but there is very limited evidence available in Pakistani context. Aimed and objectives. This study aims to assess the psychological and psychosocial changes in the students during home quarantine, and it aims to see the measures to counteract which is adopted by university students who have been home quarantined during COVID-19 pandemic. So let's have a look at the methodology. This was an online survey conducted with various universities of Pakistan, including University of Punjab, King Edward Medical University, University of Health Sciences, and it was a cross-sectional survey conducted from 20th June to 15th July. Google Forms were used, and it was a non-probability convenient type of sampling. An online survey was conducted and a sample of 1,527 students was collected within 1 week of generating the questionnaire. Duration of lifetime, psychosocial changes and coping strategies and exposure to information regarding the pandemic were the 4 variables of the study. Levels of depression and anxiety among students were assessed using DSM-5 scale. Analysis of the data. After getting the data, it was coded and analyzed with SPSS variant 23. Results were presented in the form of frequency tables and bar charts. Bivariate analysis was done. Chi-square test was applied for bivariate analysis and p-value was fixed at equal to or less than 0.05 as significant value. And most importantly, before conducting this research, ethical issues including IRB approval and confidentiality of the data was taken into consideration. So let's have a look at the results. The total number of university students who completed the online questionnaire was 1,527. The maximum number of students was between the age bracket of 21 to 23 years, numbering as 990. Majority of the participants were female students, and more than 34.6% of the participants reported period of home quarantine for more than 4 months. This is a table with socio-economic demographic profile of the student with 4 variables: age distribution, gender distribution, duration of quarantine, and student tested positive for COVID-19. Out of 1,527 surveyed students, 204 were already suffering from any psychological disease. Remaining data of 1,323 students was evaluated to find out the effects of home quarantine. In response to our questions, most of the students complained about lack of concentration, lack of interest in doing anything, feeling of irritability, annoyance, and fatigue. So this is the frequency table which shows you the frequency of symptoms related to psychosocial health among students, with lack of concentration on the top with a coping percentage of 69.9%. After applying DSM-5 scale, signs and symptoms found were as follows: anxiety, which was reported in 872 students, depression reported in 828 students. These students opted multiple coping strategies which are as follows: watching online movies and seasons in 928 students, extracurricular activities like painting in 376 students, social media usage in 743 students, only 476 students opted for improving academic skills, 56 students started using antidepressants, 69 students started smoking, and 29 students started using drugs to relieve stress. And most commonly, females were more affected with psychosocial changes than males in home quarantine. So let's have a look at the discussion. COVID-19 has affected the individuals belonging to all social and racial groups. University students are the most affected population, and they have suffered economic loss as well as social loss. And they are already prone to depression and anxiety due to their academic challenges. Worldwide literature shows that this pandemic has affected mental health of the general population, as well as it has long-lasting effect on psychosocial health of healthcare providers as well as students. In order to overcome this frustration, this youth has adopted certain coping strategies, which include watching online movies and seasons in 60.8% people, using social media, smoking tobacco, using narcotics. The most effective strategy reported was exercise, but was very limited in Pakistan, unfortunately. So ending my presentation with this conclusion, COVID-19 pandemic has created a lot of stress in all sectors of life. Especially students have faced psychosocial changes during home quarantine. A large number of students suffer from depression, and female students are more. Thank you so much, and have a good day.
Thank you very much, Ashil, for this very informative paper on COVID-19 depression. While the judges are compiling the result, I will ask you to keep the result secret, and we are not going to announce it right now, and we'll keep it for the concluding session at the end. Now, since we are short of time, I will request only two panelists to please comment on this session. You can comment on any paper if you like, or if you like to have a general comment. So first, I will request Mr. Tariq Wasim to please have a few words.
Thank you. First of all, I must thank the organizers for inviting me to be here, because I still feel myself part of the faculty of the same medical academics here. And I'll be very brief. This session was very, I would say, simple. The topics selected, both diabetes as well as NAFLD, they are very, and of course both these speakers have highlighted the importance of lifestyle changes in both the diseases, whether it's diabetes, whether it is NAFLD, and now we are thinking of their spectrum of disease, metabolic disorder. So the presentations were definitely highlighted. Commenting on the second component, I think again the selection of the research topics and articles are very brief, crisp, simple, and they were relevant studies to our own local scenario. Typhoid remains a very important problem for us, and Prashant mentioned about the rising this trend of multi-drug resistance or extensive drug resistance typhoid. Pfizer's paper, again a very simple, novel technology that we know albumin is very expensive. It's not most of the time available. If you have an alternative to that, particularly resistant ascites or paracentesis, that's again very good presentation, I think. I mean, there was some thing to be mentioned about comparing the sputum and tracheal secretion. Something I think probably there was it is not equally comparable. Sputum in most of the OPD patient is not usually the sputum, it's more saliva mixed with that. Tracheal secretion is obtained from within the endotracheal. So I think the comparison drawn from that is comparing sputum with these secretions. But anyway, it again highlighted. So these are good studies, and again encouraging that our medical students and young are presenting that, and that's the way forward, that we have to encourage this culture of not only doing an indigenous local research, but also train them to how to present at a clinical forum. Thank you.
Thank you very much, Mr. Tariq Wasim, for your valuable comments. Because of lack of time, we are going to summarize the whole panel of experts in one person, and he is none other than Professor Zafar Iqbal Chaudhary. We are running out of time. So I will just thank my guest speakers, Professor Rizal Maan, Professor Mahmood Hassan Malik, and all my co-chairmen, Professor Tariq Wasim, Professor Latif, Professor Rizwan, and Professor Samia. And I will also thank the moderator, Professor Mujbal, for conducting this session very efficiently and very actively. And I am also thankful to all the audiences for their patience listening. Thank you very much. So after the vote of thanks from the chief of the panel of experts, we are going to conclude the medicine session right now. There is a change in the program, so we are not going to have a tea break right now. Tea will be served in the hall. So we are going to start the surgical session straight away. So over to you, Professor Khalid. Thank you very much.
Bismillahirrahmanirrahim. Good morning and Assalamu alaikum from Department of Surgery. I am Professor Khalid Mahmood. On behalf of Surgery Department, I cordially welcome you all to the first scientific symposium of Dr. Said Medical and Dental College. Dear fellows, we are living in the era of science and technology, where research and innovation are the tool for success. Following the international trends, we believe that there was a need to strengthen AMDC's research activities. Therefore, under the visionary leadership of Dr. Farooq Saeed Khan, the idea of holding an annual symposium came about. The main force behind this idea was the timely judgment of Dr. Umair Farooq, who is always on the front to lead the AMDC team. We are truly thankful for the guidance and efforts of Dr. Farooq Saeed Khan and Dr. Umair. Now I will request the panel of chairmen to take their seats. First of all, I will Professor Dr. Munir Imran to come on the stage as the chairman of this surgical session. I will request Professor Ishfaq Ahmed, Head of Department Surgical Unit 1, please come on the stage. Professor Dr. Wasim Asmat, Head of Anesthesia Department. Dr. Farooq, Head of Orthopedic Department. Sir, please take your seat. So there is a change in the sequence of this session. I will start with the state of art lectures, but unfortunately our both guest speakers are on the way. So we are starting with the scientific papers by our respected students and the postgraduate residents and house teachers. The first topic of today's presentation is by the Surgical Unit 1 by Dr. Hamad. He is a PGR in Surgical Unit 1. The topic is comparison between modified Alvarado score and Vipasa score in Southeast population with histopathology as a gold standard. Stage for your presentation.
Assalamu alaikum and good morning. I am Dr. Hamad Mahmood from the Department of Surgery. I am the Chief Surgical Registrar in Surgical Unit 1. Our research paper is titled A Comparison Between the Modified Alvarado Score and the Vipasa Score in a Southeast Asian Population with histopathology set as the gold standard. This paper was authored by myself and 3 consultants. Ethical approval was obtained and we have closures to make. Acute appendicitis is one of the most common conditions that presents in surgical chaos worldwide, with an incidence of approximately 100 per 100,000 person years and a prevalence of 14%. However, despite this, the diagnosis can be challenging at times, as there are a number of other conditions which can present with similar symptomatology. An early diagnosis is essential, as missed and delayed diagnoses can lead to adverse outcomes. It is also important to reduce the number of negative laparotomies, as these lead to an increase in patient morbidity, as well as increase the burden and cost of healthcare on hospitals. To help aid in the clinical diagnosis, a number of clinical scoring systems have been developed over the years, some of which are displayed here. The Alvarado and the modified Alvarado scores are the most common of these. The Alvarado was initially designed to diagnose acute appendicitis in pregnancy and then later adapted for use in the general population as the modified Alvarado score. It is one of the most commonly used scores due to its simplicity. However, it has been known to be less efficient when used in an Asian population. It has 7 variables with a maximum possible score of 9, and scores of greater than 7 are highly suggestive of acute appendicitis. The Repasa score was developed specifically in 2010 to help improve diagnostic accuracy of acute appendicitis in Asian populations, and it takes its name from the hospital in Brunei Darussalam where it was initially developed. There are 14 variables decided upon to create the scoring system. These are the variables displayed here. There is a maximum possible score of 16.5. Scores of greater than 7.5 are highly indicative of acute appendicitis, and scores of greater than 12 are considered to be diagnostic. Our objective of the study was to compare both scores for diagnostic accuracy when applied to the local population. This with 150 patients, both scores were calculated for each patient at the time of presentation. If the modified Alvarado was greater than 7 or the Repasa was greater than 7.5, the patient was labeled as having acute appendicitis and advised admission and surgery. If this criterion was not met, the patients were admitted for observation and conservative management. During this time, if the patients showed no improvement or they worsened, then they underwent surgery as well. We included patients of both genders who were between the ages of 10 and 60 years and who presented with pain in the right iliac fossa for less than 7 days. Patients who had comorbidities and those who had complications arising from appendicitis were excluded from our study. Informed consent was taken from all patients or their legal guardians, and the excised specimens were sent for histopathology. We took the presence of neutrophilic infiltrates in the muscularis propria as confirmation of our diagnosis. With regards to patient demographics, there was a slight female preponderance in our study population, with most of our patients between the ages of 21 and 30 years of age. Following pain and tenderness in the right iliac fossa, which were present in all of our patients, fever and leukocytosis were the next most common presenting features. 77% of our patients had symptoms for less than 48 hours, and a positive urinalysis was present in approximately half of our patients. The Ropsin sign was present in just over a quarter of our study population at the time of presentation. The Repasa was suggestive of acute appendicitis in 79% at time of presentation, whereas the modified Alvarado was suggestive in 61%. The final histopathology report was positive for acute appendicitis in 79% of the excised specimens. We were sensitivity and specificity of 64% and 53% respectively for the modified Alvarado score, with the diagnostic accuracy of 62%. For the Repasa score, the sensitivity was calculated to be nearly 90%, the specificity of 59%. The diagnostic accuracy was higher at 83%. These are the results of both scores compared side to side. The negative appendectomy rate for the Repasa score was significantly lower, with a p-value of less than 0.01. And a number of other studies have also been done, both regionally and internationally, evaluating the efficacy of the Repasa score. Results from our study, as well as the original study by Chong, are shown here, compared with select studies from the Indian subcontinent, the Middle East, a study done in Ireland, and a meta-analysis done in Greece in 2018. We were able to achieve similarly good results as these other international studies. This is a comparison of our study with other studies done in various cities within Pakistan, and again, we had similarly good results. Our study findings show that the Repasa score is superior to the modified Alvarado for diagnosing acute appendicitis in the local population. And interestingly, scores of greater than 7.5 can be achieved even without the use of any lab investigations, thereby saving valuable time and resources in a selected group of patients. Our study was not without its limitations. Our sample size may not be large enough to generalize these results to the broader population, and exclusions of patients with comorbidities and complications may limit the use of our findings to patients who are more diverse. Our conclusion from this study is that the Repasa score is a more reliable tool and can be used effectively in place of the modified Alvarado score in the ER when evaluating patients with suspected acute appendicitis. These are the references for our study. I thank you for your time.
Thank you very much, Dr. Namaz, for an excellent presentation. The next paper in line is by the orthopedic department. The title of paper is Are You Suffering Pain Neck Due to Phone? Text Neck Syndrome. And the presenter of paper is Osama Amjad. He is a final year student. Please welcome Osama Amjad.
Starting with the name of Allah, who is the most merciful and most beneficent. I am Muhammad Osama Amjad, student of final year MBBS, and I am here to present our case of text neck syndrome. So, are you suffering from pain in neck due to use of gadgets? Coming towards the introduction, smartphone and other gadgets are widely used across the world. Almost every person uses a smartphone these days, not only for work purpose, but also for entertainment and gathering information. The prolonged usage of smartphone and other handheld devices in a static posture can lead to increased pressure on neck muscles and consequently cause pain in the neck. This is people who use laptops in a wrong posture. In a contemporary world, it is almost impossible to stay away from smartphone, but its usage in a static posture for prolonged hours invites cervical issue. Coming to a basic overview, text neck syndrome is a condition in which pain in neck results due to prolonged or excessive usage of smartphone or other handheld devices over a sustained period. Bending over and looking down on the smartphone in a turtleneck posture for prolonged duration results in pinching of cervical nerve due to increased pressure on cervical spine. Consequently, symptoms such as neck pain, stiffness, upper back ache, shoulder muscle tightness, and pain appear in the individuals having this condition. Headache, vertigo, tingling, and numbness can be seen as well. Management is primarily prevention, avoidance of excessive smartphone usage, frequent breaks during work, keeping the gadgets at eye level, and accurately. So, how your spine? As you can see in this picture, force on the neck increases the more we tilt our head, causing spine curvature. So as that ankle is increasing, the force on the neck is also increasing. At 0 degrees, it is just about 10 to 12 pounds. So as it increases to 15 degrees, force on neck is about 27 pounds. At 30 degrees, 40 pounds. At 45 degrees, 49 pounds. And at 60 degrees, the force on neck is around 60 pounds. This is an another picture. You can well appreciate the more you bend, the more you forwardly bend your head, the more force on the neck muscle increases. So what was the objective of our study? To determine the prevalence of different causes of text neck syndrome among medical undergraduate students of Akhtar Said Medical and Dental College. Coming to its methodology, it was a cross-sectional study design conducted from June to July 2018, setting in setting of Akhtar Said Medical and Dental College. We study population medical undergraduate from fourth and final year. Sample size 101 medical undergraduate students. And for the non-convenient sampling technique, our inclusion criteria was all medical undergraduates who were using smartphone, tablets, and laptop for the past 6 months duration, students willing to participate, students using smartphone for more than 2 hours per day. Our exclusion criteria was students with a history of cervical spine trauma or any neurological symptom, or those students who were not willing to participate, or those with incomplete questionnaires. Data collection and analysis, students were asked about their daily usage of mobile phone, and they were informed about the study that we were going to conduct. And informed consent was taken from all the participants. Information was collected from a structured questionnaire with basic demographic details such as name, age, gender, and number of hours spent on the phone. The questionnaire was made after going through Neck Disability Index. This was our questionnaire in which we had asked 10 questions regarding pain intensity, reading, lifting, headache, etc. So this is an scoring of our how we score about Neck Disability Index. In this, you can appreciate each of the 10 sections scored separately from 0 to 5 points each, and then added up to maximum total 1250. So, for example, in question 1, the pain intensity was asked, and if a person says, I have no pain at the moment, the point value was 0. And if the pain is worse imaginable, the point value is 5. And if all 10 sections are completed, simply double the patient's score. And if a section is omitted, divide the patient's total score by number of sections completed times 5. The formula is quite important. Patient score divided by number of sections completed times 5 multiplied by 100 will give us the percentage disability. So coming to the results, in our study, out of 101 students, 59 were female and 42 were male. The age of student was around 25 years. Time since using smartphone was around 5.5 years. The preferred gadgets, cell phone was most commonly used around 48%. Then come the tablets and laptops, and cell phone and laptops both combined. Time of daily use of gadgets or technology was around 5.5 hours. Preferred method of statement connection was calls, text, and both calls and text. So, result of our study showed that out of 43 males, 24 had no disability, while 15 had mild disability and only 4 had moderate disability. Coming to the females, out of 58 females, 37 had no disability, 16 had mild disability, and 5 had moderate disability. Majority, 62.4% of the students felt conscious stress in the neck, 20.8% had off and on stress, whereas 17% said that they had this complaint while using cell phone. Out of 101 students, 58.4% students did not have any disability, 30.7% students have mild disability, and 9.9% of students have moderate disability. So these are our results shown in the form of bar charts. And coming to its conclusion, the pain due to chest neck syndrome was male than female. It was more common in female. The lack of knowledge about warm-up exercise, use of correct posture, taking break while using smartphone and handheld gadgets was acting in most students. The prolonged usage of cell phone is associated with greater frequency of neck pain and a higher neck disability index score. Initially, the musculoskeletal changes are short-term, but can cause disabilities later in life if proper care and prevention is not taken. The limitations were that the sample size was not that large and study was carried in single institution. Flexion angle was not measured in our study. Posture-related awareness while using smartphone and other handheld gadgets were not included. Coming towards the recommendations, a larger study will generate more evidence that will help in prevention of this condition. A multi-center study will prove to be more beneficial. Awareness of chest neck syndrome and right posture should be raised among students and other youngsters to avoid issues of cervical spine at a young age. The youngsters should be encouraged to reduce screen time and take breaks while using handheld gadgets to reduce the pressure on cervical spine. The mobile phone should be held high while being used to that they align with their eyes, reducing strain on the neck muscles. These are all the references, and thank you so much.
Thank you, Sama, for your excellent presentation. We, Akhtar Said Medical and Dental College faculty, teachers, principal, all warmly welcome to our distinguished guest, Professor Mahmood Ayaz, who has spared time for our institute. He is the current Vice Chancellor of King Edward Medical University, ex-principal, Services Institute of Medical Sciences. He has trained numerous surgeons all over Pakistan. Professor Mahmood Ayaz made accomplishment in medical field one can only dream of. He is the pioneer in latest surgical procedures in Pakistan. He is an inspiration and role model for many surgeons. I am thrilled to listen pearls of wisdom and knowledge from Professor Mahmood Ayaz. Please welcome Professor Mahmood Ayaz for his talk on recent advances in surgery and robotic surgery. Thank you.
बिस्मिल्लाहिर्रहमानिर्रहीम, अस्सलाम वालेकुम। मैंने आपको सलाम किया सबको। That makes me alive as well. Thank you very much. So it's great coming here. अभी मेरे बारे में कुछ अल्फाज कहे जा रहे थे। जब ऐसे अल्फाज मेरे बारे में कहे जाते हैं और जब मेरे उस्ताद मेरे सामने बैठे होते हैं तो मैं सवाई शर्मिंदगी को और कुछ मुझे ऐसा महसूस नहीं होता। मेरे बड़े मुख्तरम उस्ताद यहाँ पे बैठे हुए जिनसे मैं फर्स्ट ईयर सेकेंड ईयर में बाकायदा बैठ के बेंचों में उनके सामने पढ़ा, प्रोफेसर हामिद जवेद कुरैशी साहब। सर आज तक मैं जो कुछ भी हूँ, जैसा भी हूँ, उसकी तमाम खूबियों के जिम्मेदार आप हैं और कोताहियाँ मेरी सारी अपनी हैं। तो मैं बहुत ही शर्मिंदगी महसूस कर रहा था कि मेरे आप जैसे मुख्तरम उस्ताद के सामने मेरे बारे में कोई कलमात कहे जाए, तो सवाए शर्मिंदगी को और कुछ मैं महसूस नहीं करता। आपकी बड़ी मेहरबानी, आज आप यहाँ पर तशरीफ रखते हैं और इसके साथ साथ मैं बहुत ही शुक्रगुजार हूँ प्रोफेसर वनीला का। और मैं तो फरूक भाई जो हूँ आपको सर, आप जितने भी तरक्की करके लेकिन हैं मेरे भाई, तो आपका शुक्रिया अदा करूँगा कि आज आपने मुझे मौका दिया कि मैं कुछ यहाँ पे आके अपने स्टूडेंट्स के साथ बैठ के बात कर सकूँ। सो आप इजाज़त के साथ सर, हम क्वेश्चन सर इजाज़त के साथ शुक्रिया सर। So I'm going to talk about, professionally, if you know that I'm a surgeon, and I'm going to talk about the artificial intelligence's role in minimal invasive surgery. So that is what I'm going to talk about today. It will be a bit, about 20 minutes talk, because because I want to show you a few videos just to make you interested in what is all robotic surgery about. But before I do that, let me just introduce what I'm going to speak about. As when we're all surgeons, we are all sitting here, and many of you are my colleagues. When we were training, a general dictum tha कि big surgeons will make big incisions, surgeons will make middle grade incisions, and small incisions were looked down upon. अच्छा नहीं था, समझा था कि छोटी छोटी इंसिजन लगा के कहते नज़र तो आता नहीं है, तो ऑपरेशन क्या रहेगा करने आप, एंड दे वर वेरी राइट. सो वी applied big incisions and actually do the surgeries like abdominal, thoracic surgery or any kind of surgery. But the patient's perceptions were totally different. Patients wanted safe surgery, precise surgery, which was painless, and a very rapid recovery. ये patients की demand. So what did was to actually bridge the gap between the patient's expectations and what the surgeons thought about surgery. So this robotic surgery, which I'm going to talk about, it actually bridges the gap between the expectations of the patient और जो हमारी perceptions के surgeon through bridging technology. वो मैं भी आपको दिखाऊंगा कि वो how to do that. So you must remember that robotic surgery is just a natural sequelae of laparoscopic or minimal invasive surgery. It's nothing new. Because it came to an era when patients were demanding a lot of painless, precise, and a very efficient surgery. उस ज़माने में आया तो doctors और मेरे जैसे जितने भी हम trained surgeons यहाँ पे सारे बैठे हैं, we were already doing a lot of minimal invasive surgery. Because minimal invasive surgery did carry a lot of advantage, because आपको पता है कि छोटे इंसिजन होते हैं, कम दर्द होती है, रिकवरी अर्ली होती है, बैक टू वर्क, लेस अमाउंट ऑफ ब्लड लॉस होता है. So that is the greatest advantages. But the greatest advantage of minimal invasive surgery is that आपको पता है कि जब भी कोई चोट लगती है, सर्जरी एक तरह की चोट है ना, जब भी आपको कोई चोट लगती है तो बॉडी एक मेटाबॉलिक रिस्पॉन्स जनरेट करती है, एक इन्फ्लेमेटरी रिस्पॉन्स जनरेट करती है. तो जितनी ज़्यादा मिनिमल एक्सेस होगी सर्जरी की, उतना ही कम इन्फ्लेमेटरी रिस्पॉन्स जनरेट होगा, उतना ही कम मेटाबॉलिक इंसल्ट पेशेंट को होगी. इसी यही वजह है कि पेशेंट्स दे वुड शो अ रैपिड रिकवरी. And this was distinctly proven when robotic surgery came into being through various randomized controlled trials, that it was distinctly proven that robotic surgery has got a distinct advantage, especially in the obese and the elderly people, because it carries a lesser amount of blood loss, an early recovery, lesser conversion rates, and early back to work, and a very late, not a very late discharge from the hospital. So it had a distinct advantage. But robotic surgery के advantages क्या हैं? Advantages जो है मैं चार आपको गिनाऊंगा, फिर one by one को explain करूंगा कि advantages थे क्या. Number one was better visualization. Second, the presence of the robotic wrist. Third is the improved kinematics. मैं सारा आपको explain करूँगा what does it mean by these things and better ergonomics. So let's talk about the better visualization. Robotic surgery definitely gives you a better visualization. It gives you a 3D visualization. मैं इसको थोड़ा सा आपको explain इस तरीके से करूँ कि देखें हमारी जो दोनों आंखें, any eye surgeon sitting here, our both eyes are fixed into our eye sockets in a way that there's a fraction of a millimeter of difference in position. So that what my right eye sees, the image is here, what my left eye sees, the image is here. And when there is subtraction of these images into our brain, this gives us the depth perception. So that is what is known as 3D vision or stereoscopic vision. But this 3D vision is lacking in laparoscopic surgery. तो इसका greatest advantage ये था कि ये बहुत आपको help करती है precision dissection में. And as surgeons they grow old, like me as I'm growing old. आप जितने भी काबिल surgeons हो आपके हाथ में tremors आना शुरू होते हैं. Robotic surgery takes away those tremors. Those tremors, even if they are in your hands or your arms, they are not reflected into the area where you are operating. So that is a great advantage. So आपकी visualization बेहतर होती है, आपका hand control बेहतर हो जाता है. इसके साथ क्या होता है? The better kinematics. आपकी जो long range of movements है जब आप करते हैं, देखिए जब आप operations करते हैं ना, तो आपकी 7 movements दरकार होती हैं. There are 3 movements: abduction extension here, flexion extension and rotation. ये यहाँ पर shoulder पे होती है. Flexion extension आपकी elbow पे, फिर pronation and supination होती है, फिर wrist के ऊपर आपकी flexion और extension और lateral movements होती है. तो आपको सर्जरी करने के लिए 7 movements दरकार होती है. और open और laparoscopic सर्जरी में यही 7 movements आपको दरकार होती है. But in robotic surgery, you do not use your shoulders, you do not use your elbows, you only use your wrists. So this is the first time in the 1000 years of history of modern instrumentation of surgery. This was the first time an instrument was devised which can go into a cavity and mimic like a human wrist. अगर आपने A.G. Wells की किताब पढ़ी Outline of History तो उसमें उसने लिखा हुआ है कि in the evolution process the human race got an advantage over all the other species just because the human race would possess a wrist. ये animals में wrist नहीं है. वो कहते हैं it's not your intelligence, it is not your instinct which distincts the human race from the other animal species. It is the wrist of the human because humans ने इस wrist की मदद से हथियार बनाए, तीर कमान बनाए, शिकार करने की चीज़ें बनाई, अपने से 4-4, 8-8 गुना बड़े जानवरों को मार गिराया और इसी के साथ खेती बाड़ी के टूल्स बनाए और इस ह्यूमन रिस्ट ने इसको डिस्टिंक्ट एडवांटेज दिया ओवर ऑल द अदर स्पीशीज. चिंपैंजीज थोड़ी सी इस रिस्ट को पोजेस करते हैं बट नॉट एनी अदर स्पीशीज. So this 360 degrees of rotation of the human wrist inside the human body, and not only 360 degrees, I'll show you, it is 720 because it can reverse back and do the surgery in the reverse way. So that is the greatest advantage with the robotic surgery that possesses a human wrist. और ये better kinematics जो ना help करते हैं आपको उन close spaces में काम करने की जहाँ पे वैसे आपके लिए चीज़ें accessible नहीं होती, like deep down into the pelvis, like doing prosthetic surgeries, rectal surgeries, doing surgery in the right hypochondrium and left hypochondrium. और जब मैंने robotic surgery से cranial resections करनी शुरू की और मैंने adrenalectomies करनी शुरू की, तो मैंने सोचा, मैंने कहा सारी उम्र किस दुख में हमने गुजारी है कि किस मुश्किल में ऑपरेशन थे and how easy they have been made. And because you can identify to the greatest of magnifications to all the nerves and blood vessels, so tumors which were considered to be inoperable, now they're operable through the robotic surgery. So that is what is better kinematics. And then there are certain excellent ergonomics. Ergonomics means the price you have to pay for a movement. तो जितनी लंबी सर्जरी होती है बिकॉज अपने शोल्डर्स के ऊपर अपने एल्बोज के ऊपर स्ट्रेन कर रहे होते हैं, अपने नेक पे स्ट्रेन कर रहे होते हैं, हिप्स पे टांगों पे स्ट्रेन, यू गेट फटीग्ड. बट in robotic surgery you are sitting on a console, you are resting your hands on a boulder and you are only moving your wrist और आप अपने हाथों के छोटे मसल्स को इस्तेमाल कर रहे होते हैं. So the amount of energy which you're spending for the purpose of doing the surgery is enormously reduced. So the amount of fatigue is very much reduced. So these are certain distinct advantages which robotic surgery brings to you. Just a visualization of what we do. This is my operation theatre environment, and this is my, मैं आपको बताऊंगा कि robot आपको कैसे guide करता है कि आपने अपनी port placements कहाँ करनी है. So this is my robotic theatre in the National Hospital. We are trying to get one robot for Mayo Hospital, 2 robots for Mayo Hospital. Probably in March we'll be able to install them there as well, so that we'll be able to train more and more people. So like if I have to operate upon, like I'm operating here on a low rectal cancer, so these are my port placements. आपको जो map दिया जाता है through the robot के what will be your port placement through artificial intelligence, and then you place the ports and then you go ahead with your procedure. I'm just this is just to show you that how does it work actually. This is basically a case history of a 60-year-old female who presented with a VDPR. हमने की downstaging कराई through giving newer geometry. Explain करना चाहता हूँ. I am doing a lower anterior section, and you can see that this is the I've lifted the rectum up and mesorectum. And you can see that this is the instrument, and you can see multiple joints on this instrument, and this can actually move just like a human wrist. And this is my other hand, and you can see that the movements, whatever I want to do with my wrist, these movements are replicated while I'm sitting on a console, on the instrument. So this allows you to work in a very close space with a better visualization. So I'm just trying to lift up the rectum, and I'm doing the mesorectal dissection, and the magnification is such that you are able to see the minutest of the details. And you can see that it's like a cadaver operation, but this is a live patient. You can see the uterus over here, and I'm just doing it because it magnifies things to such an extent that you can see each and every small blood vessel, and you can identify the avascular planes, and you can go into the avascular planes very nicely and efficiently. And you can see that this is the sacral promontory, this is the sacrum, and I'm moving my way towards I'm doing the posterior dissection first. So I'm moving my way down towards the pelvis. Normally this surgery becomes more and more difficult, even when खासतौर पर अगर जब आप ओपन सर्जरी करें तो बहुत ही मुश्किल है. लैप्रोस्कोपिक सर्जरी में भी इस किस्म की विजुलाइजेशन चूँकि अवेलेबल नहीं होती, सो ये इस तरह की डिसेक्शन की आप इतनी नाइसली you just sit on a console and you just paint like an artist. आपको लगता है कि आपके हाथ में पेंट ब्रश है, which is being very efficiently used. It's really pleasurable, it's really very enjoyable. मुझे सर्जरी वैसी बड़ी पसंद है, लेकिन आप ठीक है मुझसे पूछे तो मज़ा सर्जरी का अभी आना शुरू हुआ है कि कितना मज़ा आता है ऑपरेशन करने में. Don't think that I'm a bloodthirsty person, लेकिन मज़ा बड़ा आता है ऑपरेशन करने के लिए. So this is the whole of the pelvis that I have been able to dissect. ये सबसे पहले मैंने posterior dissection की है. The whole of the rectum has been lifted with the mesorectum. हम पहले mesorectum का नाम ही सुना करते थे, लेकिन जब रोबोटिक सर्जरी करनी शुरू की और लैप्रोस्कोपिक करनी शुरू की तो पता चला कि वाकई mesorectum एग्जिस्ट करती है. I've left all the sacral plexus of the nerves, all the sacral plexus of the veins behind. Normally यही एरिया होता है जहाँ पे बहुत ज़्यादा ब्लीडिंग होती है, but you can see the ease of dissection. अब मैं थोड़ी सी इंटीरियर डिसेक्शन कर रहा हूँ ताकि मैं इसको यूट्रस और यूनिब्लैडर से इसको सेपरेट कर दूँ. So I will go all around and then I'll identify the inferior mesenteric artery and ligate that. But that is a long video. मैं तो सिर्फ यहाँ पे आपको दिखाना चाहता था कि क्लोज स्पेसेस के अंदर जो मूवमेंट्स हैं इंस्ट्रूमेंट की वो कितनी एफिशिएंट है और किस तरीके से आप अपनी हर एक इंस्ट्रूमेंट को बेंड कर सकते हैं जिससे आपकी अपनी रिस्ट ह्यूमन बॉडी के अंदर और अपना काम करते चले जाते हैं. Only that you have got a great visualization and you can actually go ahead and do whatever you want. This is one of the most common procedures which all the surgeons they perform. और इसको आपने देखा this is a cholecystectomy, relatively a very easy operation to perform on with the help of a robot. So this is what I'm doing for the posterior dissection. यहाँ पे भी आपकी सबसे बड़ा एडवांटेज है कि कैमरा आप बिल्कुल उसकी बैक पे ले जाते हैं. I've never seen the goblet from the back in such a nice way. And you can see the visualization. इससे लगता है कि जैसे सब कुछ किताब आपके सामने खोल के रखी हुई है. So this was relatively an easy kind of surgery, but you can see the flexibility which I have with this instrument and the speed which I can work and the vascularity which I can generate with this instrument is remarkable. So now I'm trying to go anteriorly, trying to do the dissection. This is the traditional teaching कि आप हमेशा पहले posterior dissection करते हैं, रूबियस सर्कस को आइडेंटिफाई करते हैं, ग्लोब्स को आइडेंटिफाई करते हैं, कैलस ट्रायंगल को डिसेक्ट आउट करते हैं और उसके बाद आप then you start doing the clip placement. So you can see that the kind of movements which I can perform inside the abdomen, they are enormous. I'll further skip this video because this is just to show you that what kind of instrumentation you use और कितनी अच्छी efficiently आप इसको use कर सकते हैं. There is a slight learning curve for robotic surgery. ऐसे नहीं कि एकदम से आप इसको शुरू कर देते हैं, but you need to actually get a bench training. आपको पहले 15 modules करने होते हैं. You have to show 500 working hours on a training module. Then you are taken to the models and then ultimately to the cadavers before you are brought to the human beings. और उसके बाद फिर आपको non-complex technical procedures कराए जाते हैं, like getting a biopsy, doing an appendectomy, and then you move on to really challenging and demanding cases like cholecystectomies, hernias, and no sections and rectoplexes. So definitely it has been statistically proven that there is a distinct advantage. This is what we do. The robot gives you a console all the time. And this is the console of my robotic procedures last night. इसके आप देख सकते हैं कि जो last मैंने procedure किया है, 24th of October, 9:31 p.m. So everything is documented and you get a dashboard जहाँ पे each and every data, the name, the age, the sex, and the type of procedure which has been done, the surgeon who has been performing, the time taken for the surgery. This is the data which is generated by the computers and this cannot be plagiarized. हमारे ऊपर सबसे बड़ा इल्जाम लगता था कि हमारे मुल्क से जो डेटा जाता है वो डेटा ठीक नहीं होता. So there is no scope that anybody can plagiarize this data. Whatever you have done, it has to be documented in the form of data by the computer. This is submitted to the CMR, which is the main server in the Cambridge, जहाँ से रोबोट ने ओरिजिनेट किया था और ये वहाँ पे सारा का सारा डेटा इससे रिलेट होता है. और 283 surgeons who actually work on these CMR robots all over the world, जिसमें से एक मैं भी हूँ, वो उनका सबका डेटा मैनिपुलेट होता रहता है, टैबुलेट होता रहता है और शो अप होता रहता है. So nobody can actually put something which can be blamed upon. And it gives you complete data. It gives you the complete video recording, which is actually available to all the robotic surgeons all over the world. So anybody can actually interrupt you if you are doing something wrong or आपको further guide कर सकते हैं. The instruments which you use, वो इंस्ट्रूमेंट कितनी देर के आपने यूज़ किया है, कितनी देर के लिए आपने इंस्ट्रूमेंट को छोड़ा है, कितना उसमें ब्रेक आया है, आपकी बाइपोलर आपने कॉर्ड कब यूज़ की, मोनोपोलर कॉर्ड कब, कैमरा कितनी देर आपने यूज़ किया, इंस्ट्रूमेंट्स की लाइफ कितनी है, क्योंकि इन इंस्ट्रूमेंट्स को कुछ की लाइफ पूरी करने के बाद इसको चेंज करना पड़ता है. एंड दीज टाइम्स शो कि मेरा टोटल टाइम ऑफ सर्जरी का कितना था, पेशेंट अंदर कितने बजे आया, कितने वक्त किस वक्त आया. यहाँ पे आपको शो हो रहा होता है कि रेड लाइन से आपको शो करती है कि आपका टोटल टाइम ऑफ सर्जरी कितना था, आप कंसोल पे कितनी देर तक बैठे रहे. और या तो एक्टिव कंसोल टाइप रहता है कि आप कंसोल पे बैठ के आप गप्पे तो नहीं लगाते, आप चाय तो नहीं पी रहे थे, बिकॉज यू डोंट नीड टू टेक्स्ट fully scrubbed up to go and do this surgery. You can just sit in a console and do this surgery, or the patient is in a side room or another room. पहले तो मेरा हौसला पड़ता नहीं था कि मैं मरीज से दूर हट के ऑपरेशन करूँ, तो मैंने उसी कमरे में कंसोल रखा था. लेकिन अब जो है ना gradually I've shifted this console to another room where I do not need any kind of sterilization. I just go there and start operating. The rest of the team actually fixes the things for me. And if I have got a dedicated high-speed internet line only for me at my home and nobody else uses it, I can actually, if I have a console at my home, I can do this work right from my home. मजे की बात है वर्किंग फ्रॉम होम, तो उसमें यह है कि ये आपका जब भी मैं वहाँ पे पोर्ट प्लेसमेंट करता हूँ, द कंप्यूटर गेट्स अ मेमोरी कि मेरा कैमरा कहाँ पे था, मेरी गाइडिंग इंस्ट्रूमेंट्स कहाँ पे थे, मेरी राइट आर्म कहाँ पे थी, तो बॉडी में लेफ्ट आर्म होती है. और नेक्स्ट टाइम मैंने जब भी सर्जरी करनी है, जब भी मैंने करनी है ऑपरेट करना है, तो दी कंप्यूटर इज गोइंग टू गिव मी अ सेल्फ जनरेटेड एरिया कि मैंने अपनी पोर्ट प्लेसमेंट्स कहाँ करनी है, बिकॉज दिस विल previous टेक्निक्स व्हिच आई हैव डन, और जब मैं इस पेशेंट का और बॉडी सर्कमफ्रेंस डालता हूँ, दे विल द कंप्यूटर विल गिव मी दी पोर्ट प्लेसमेंट कि मुझे इस ऑपरेशन के लिए मेरी पोर्ट, मेरा कैमरा का होना चाहिए, मेरी जो है ना मेरा वर्किंग आर्म का होना चाहिए, मेरी जो है ना डिसेक्टिंग पोर्ट्स का होनी चाहिए. सो दिस विल गाइड मी. और ये गाइडेंस उसकी इस तरीके से है कि अगर मैंने एक प्रोसीजर करना है, सपोज इफ आई डू एन अपेंडेक्टमी विद दिस, मैं चूँकि अब काफ़ी हो गया हूँ, तो मेरी ख्वाहिश होगी मैंने ऑपरेशन करना है, तो मैं स्टेप 1 करूँगा और स्टेप 3 पे चला जाऊँगा, स्टेप 3 से 6 पे जंप करूँगा, 6 से 9 पे जाकर 10 पे जाकर क्लोज कर दूँगा. बट दिस आर्टिफिशियल इंटेलिजेंस वुड नॉट लेट मी डू लाइक दिस. स्टेप 1 से मुझे वो मजबूर करता है कि मैं स्टेप 2 पे जाऊँ, स्टेप 2 से स्टेप 3 पे जाऊँ. एंड इफ आई डोंट डू दैट, इफ आई डोंट डू दैट, तो कंप्यूटर मुझे वार्निंग देता है, फिर भी मैं अपने तो इट विल शट डाउन. क्या इस काबिल नहीं है क्या इस प्रोसीजर को लेकर क्या आगे चल सके. बिकॉज जो हम सब बैठे हुए हमें इस चीज़ का पता है कि जब भी हमारे हाथ से गलती हुई, गलती तभी हुई जब हमने एक स्टेप को मिस कर दिया. सो दिस डज नॉट लेट यू. सो इट गाइड्स यू एट एवरी मोमेंट कि आपकी मूवमेंट्स क्या होनी चाहिए, आपकी पोर्ट प्लेसमेंट्स क्या होनी चाहिए, आपके स्टेप्स क्या होने चाहिए. सो इट्स लाइक अ मॉनिटर टू यू. काम आप ही कर रहे होते हैं, बट दिस रिस्ट्रिक्ट्स यू. सो ऑल दिस डेटा इज जनरेटेड फॉर एवरीथिंग. लेकिन इसके साथ साथ और क्या ये काम करता है, और ये काम करता है कि आपका सारा डेटा हर वक्त जनरेट कर सकते हैं. लाइक यू नो व्हेन आई स्टार्टेड माय सर्जरीज इन ऑन द 29th of May 2022, तब से लेके अब तक ये हर मेरे प्रोसीजर का डेटा जनरेट कर रहा है. और डेटा जनरेट करता है कि मेरा ऑपरेटिव टाइम कितना था, मेरा कंसोल टाइम कितना था, मेरा एक्टिव कंसोल टाइम कितना था. और यू कैन सी दैट ग्रेजुअली आई एम गेटिंग बेटर. और इसके साथ साथ ये मेरी हैंड की मूवमेंट्स को भी नोट कर रहा होता है कि मेरी रिस्ट के ऊपर मूवमेंट्स कितनी है. वो मैं दिखाता हूँ कि ये क्यों मूवमेंट्स नोट करता है. आप देखें कि जहाँ जहाँ पे मेरा ऑपरेटिव टाइम ज़्यादा है, वहाँ पे मेरी जो रिस्ट की मूवमेंट्स उसी तरीके से ज़्यादा चली जा रही है. सो ये आपकी वॉल्यूमेट्रिक हैंड मूवमेंट्स को भी रिकॉर्ड कर रहा होता है. ये मैं आपको बताता हूँ कि क्यों रिकॉर्ड करता है. सो दिस विल गिव यू, शुरू में मेरा 3 महीने का डेटा आप देखें, 6 मंथ का डेटा देखें, फिर ये ओवरऑल डेटा अब तक जितनी मैंने सर्विस की उसका सारा डेटा इट इज सेल्फ जनरेटेड. आई डोंट हैव टू डू एनीथिंग एंड आई कैन नॉट मैनिपुलेट दिस डेटा एज वेल. और काम ये क्या कर रहा होता है, ये नोट कर रहा होता है कि मेरी जो रिस्ट की मूवमेंट्स कितनी है. सपोज इफ यू सी दैट यहाँ पे ये मुझे जनरेट करके दे रहा है कि मेरी रिस्ट की जो लेफ्ट रिस्ट की मूवमेंट्स जो है ना कितनी, और राइट रिस्ट की मूवमेंट्स कितनी है, जो यहाँ पे आपको नजर आ रहा है लिखा हुआ, शायद इतना क्लियरली विजिबल नहीं है, लेकिन ये आपको बता रहा होता है. माई द मूवमेंट्स ऑफ माई रिस्ट शुड नॉट बी बियॉन्ड 2 सेंटीमीटर्स, 20 नहीं चाहिए. तो शुरू में आप देखें कि मेरा यहाँ पे तो आई एम समवट 27, यहाँ पे मैं 23 हूँ. लेकिन 6 महीने के बाद जो डेटा जनरेट हुआ है वो मुझे बता रहा है कि मेरी मूवमेंट्स जो है ना वो काफ़ी हद तक मैंने इम्प्रूव कर लिया. और कंटिन्यूसली अपॉन योर वॉल्यूमेट्रिक हैंड मूवमेंट्स ये डेटा जनरेट कर रहा होता है. एंड नाउ CMR इज जनरेटिंग डेटा बेस्ड अपॉन माई ओन हैंड मूवमेंट्स कि एक सर्जन के लिए जब उसने रोबोटिक सर्जरी सीखनी है तो उसकी हैंड मूवमेंट्स कहाँ होनी चाहिए. अगर मैंने कोलिसिसेक्टमी करनी है तो मेरी हैंड मूवमेंट्स की अप मूवमेंट्स, डाउन मूवमेंट्स, राइट मूवमेंट्स, लेफ्ट मूवमेंट्स ओनली ऑन माई रिस्ट कितनी है. और अगर जो मूवमेंट्स मैं शोल्डर से कर रहा हूँ, एल्बो से कर रहा हूँ, तो ये मेरे सारे मार्क्स डिटेक्ट करता चला जाता है. सो दिस जनरेट्स अ कंप्लीट एब्सोल्यूट डेटा फॉर यू. और ये मेरी लर्निंग कर्व की साथ साथ बताता चला जाता है और चार्ट की सूरत में मैंने टैबुलेट करता चला जाता है. इफ़ यू सी तो मेरे 3 मोस्ट कॉमन प्रोसीजर्स हैं, वेंट्रल हर्निया, इन्वाइनल हर्निया और कोलिसिस्टेक्टमी. तो कोलिसिस्टेक्टमी में यहाँ पे शुरू में आई वुड टेक 120 मिनट्स. जैसे जैसे मैं आहिस्ता आहिस्ता आता जा रहा हूँ, अक्टूबर में आई हैव कम डाउन टू रिड्यूस माई टाइम टू बिलो 40 मिनट्स. तो ये प्रोफिशिएंसी आपकी हासिल करता रहता है और आपको ये गाइड भी करता रहता है साथ साथ कि आपने प्रोफिशिएंसी हासिल कैसे करनी है. इफ़ यू सी माई इन्वाइनल हर्निया, पहले मैं बहुत टाइम लेता था, ग्रेजुअली आहिस्ता 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 ये नीचे चलता चला जाता है. एनीथिंग विच इज़ बिलो देन 60 इज एक्चुअली एप्रिशिएबल. लेकिन आप देखें जब मैं वेंट्रल हर्निया कर रहा हूँ, आई हैव नॉट बीन एबल टू गेट टू बिलो देन 80 मिनट्स. So I need to significantly improve this in this area. So this gives me a complete data as well. So I must remind you, all the ladies and gentlemen sitting over here, especially interested in surgery, that I must remind you that the future is here. ये robotic surgery का future इसलिए मैंने adopt किया कि 2 साल पहले मैं सर्जिस की कॉन्फ्रेंस में गया तो मैं और प्रोफेसर वारिस, और वहाँ पे 97 डिफरेंट पेपर्स 96 रोबोटिक सर्जरी के ऊपर था, 17वां जो था वो मेरा था, जो कि एडवांस्ड लैप्रोस्कोपिक सर्जरी अबाउट एड्रेनेक्टमीज के ऊपर था। तो वहाँ पे मुझे शिद्दत से अंदाज़ा हुआ कि ये जो पेपर मेरा रखा गया इसमें तर्स खा के रखा गया है कि इतनी दूर से आया है, आदमी भी रीजनेबल लगता है, बोल भी सीख देता है, इसका तर्स खा के पेपर, वरना मेरे उस पेपर की उस एनवायरनमेंट में अंदर गुंजाइश नहीं हुई कि जहाँ पे 96 मुकाले जो है ना वो रोबोटिक सर्जरी के पढ़े जा रहे हो, तो एक मुकाला वहाँ पे, तो वहीं पे मैंने डिसाइड कर लिया कि नाउ दिस इज द फ्यूचर, आई हैव टू गो बैक, आई हैव टू इन्वेस्ट इन दिस, आई हैव टू माई सेल्फ ट्रेन इन दिस। तो मेरी बॉस्टन से 2015 हो चुकी हुई थी, बट आई डोंट हैव द इक्विपमेंट, सो दिस हैज टू बी इंट्रोड्यूस्ड। नेशनल हॉस्पिटल के बाद पीकर ने जिसको ले लिया है, न्यू हॉस्पिटल को ले, ये तमाम वो मुश्किलात हम फेस कर रहे हैं। प्रोफेसर मजीद चौधरी साहब यहाँ पे बैठे हैं, इनको पता है कि जब इन्होंने शुरू की थी लैप्रोस्कोपिक सर्जरी तो तमाम यही एतराज़ात होते थे कि यार ये क्या नया काम शुरू कर दिया, छोटे छोटे होते ही क्या करना शुरू कर दिया, इतना महंगा इक्विपमेंट है, कौन आएगा, कौन करेगा। लोगों को कन्विंस करना पड़ता था कि रोबोटिक सर्जरी करनी पड़ी है, एंड नाउ नोबडी actually comes and down to you and ask कि आप ओपन सर्जरी करेंगे, वो आपसे डिमांड करते हैं कि this you will have to perform this procedure laparoscopically, and in another few years people will come and demand you that I want to get my robotic surgery done. Most of my clients of robotic surgery is from Karachi. ये सारे लोग पहले कुत्ती जाते थे ऑपरेशन करवाने के लिए, now they come down to, सस्ता पड़ता है यहाँ पे पाकिस्तान में और लाहौर में अपना मुल्क है, ठीक है। तो this will come, so all the surgeons and all the people who are getting training in surgery and all the people who wish to become surgeons, so the students are बैठे हुए, this is the future, you will have to adapt it, there's no way out, आप इसमें से बाहर नहीं निकल सकते, ठीक है ना। Ultimately we'll find out, so the quicker we are going to do this modern surgery, the quicker we are going to learn this, the quicker हमारी universities और हमारा जो college of physician surgeons को adopt करते हैं as a fellowship, the quicker it would be, and I think that it's time that we should be actually moving forwards, and हम में से जो सबके उस्ताद और सबसे सीनियर हैं यहाँ पे बैठे प्रोफेसर मजीद चौधरी, मैं उनसे भी दरख्वास्त करूँगा कि सर आप इसमें लीड लें और आप जो है ना हमें गाइड करें आगे लेके चलने के लिए, बिकॉज वी डू वांट टू एस्टैब्लिश अ ट्रेनिंग प्रोग्राम। मैंने कॉलेज ऑफ फिजिकल सर्विस को ऑलरेडी इसका फेलोशिप का प्रोग्राम 2 साल का लिख के दे दिया और आपके रूम में से भी गुजरेगा, सो दैट इज़ वॉट वी नीड टू डू, एंड द फ्यूचर इज हेयर, कुछ उसमें काम करने की ज़रूरत है, बट रिमेंबर दीज थिंग्स वुड नॉट कम टू यू, this is never going to happen to you if you want to be a solo robotic surgeon. You need to have this team. You need to have, because whatever, मैंने भी आपसे पहले जिक्र किया कि whatever I am, अल्लाह ताला की मेहरबानी, माँ बाप के बाद तो मेरे उस्ताद के सामने पढ़ने के सारे बैठे हैं, इनकी वजह से हूँ, बट इन्होंने मुझे सिखाया कि you do not work alone. You have a good team which is very very supportive to you, और वही आपको हेल्प करती है। So I am nothing without my team. So my team is all and everything for me. Thank you very much.
जी sir. Doctor, first of all, I give you congratulations for starting a robotic surgery in Lahore. But my two questions as an entrepreneur I want to introduce in my hospitals. What is the cost of the robot and what is the disposable, what is the amount which we spend on the disposable?
अब आपको पूरी बात बता दूँ सर, इस तरह है कि जब ये हमने नेशनल हॉस्पिटल इंस्टॉल किया ना तो कॉस्ट वाज 60 करोड़, तो जब हॉस्पिटल में बात तो I had to convince my board that this is very important for us. तो उन्हें कहा अच्छा ठीक है, आपको हम नया तो डेडिकेटेड ऑपरेशन करते हैं। अब आपने ये सवाल पूछ लिया, मैं उसको बता भी देता हूँ। ये पैशन है आपके काम करने, ये प्रोफेशन तो है ही नहीं, ये तो आपकी सिर्फ पैशन है कि आपने कैसे काम करना है। जब हमने इन्वेस्टमेंट मांगी तो द हॉस्पिटल वाज नॉट रेडी टू गिव अस द इन्वेस्टमेंट। I sat down with Professor Waris, Professor Wasim Nihan, two of my colleagues from urology and 3 of my colleagues from gynecology. So there's a group. तो हमने कहा हम इसको पैसे को इन्वेस्ट करते हैं, हम खुद इन्वेस्ट करते हैं। हॉस्पिटल ने तो नहीं दिया, उसमें हॉस्पिटल का जगह दे देंगे, थिएटर भी बना देंगे, आपको पैसा आपको पे कराएंगे। तो इतना पैसा तो हमें से किसी के पास होता है कि मेरे साथ इतना सारा पैसा इन्वेस्ट कर सके। तो बहुत ही पर्सनल आपको अपना सवाल पूछे बात करने में, तो वी हैड टू प्लेज, सो आई प्लेज द हाउस विच आई लिव इन टू द बैंक and got 10 crore rupees. तो मेरी बीवी ने कहा कि उनकी क्लास में कहा कि तुम बिल्कुल ही उलट गया तुम्हारा दिमाग, जिस घर में हम रहते तुमने वही बैंक के हाथ रखवा दिए। मैं कहते कि बात यह है कि अगर हो गया तो बहुत अच्छा हो जाएगा, नहीं हुआ तो कोई अफसोस नहीं इसमें। तो सर ये इसी नियत से करना चाहिए। So the initial investment is huge, बहुत ज़्यादा है, पर फिर देखिए ना तो कोई इसमें कोई धागा इस्तेमाल हो रहा है, ना तो ब्लेड इस्तेमाल हो रहा है, ना तो इंस्ट्रूमेंट इस्तेमाल हो रहा है, कुछ भी नहीं आपको करने की जरूरत। रीयूजेबल तो मतलब कोई प्रॉब्लम ही नहीं है। The cost of surgery at the end is less than open surgery, and in the end is much lesser than the laparoscopic surgery. जी वो 3-4 लाख we have to pay the company 1,60,000 rupees per case, ठीक है। अच्छा, अब वो जो हम लैप्रोस्कोपी में करते थे, थिएटर में करते थे, उसमें यह है कि एक टोटल पैकेज, सपोज एक पेशेंट है उसको 3 लाख की सर्जरी करनी है, तो उसमें we also decided that for the initial 100 cases we are not going to earn anything from this. अब भी जो है ना, मतलब मैं आपको बता नहीं सकता कि what do we earn from this, मतलब इतने वो शर्मनाक हद तक कम है, but we still accept because we just want that this kind of surgery should be popularized. The rewards are going to come. The rewards are not going to be monetary. The rewards are going to be in the form of the public service which we are going to extend to the people. So it will be there. और क्योंकि आप बहुत बड़े एंटरप्रेन्योर हैं, तो मेरी तो बड़ी ख्वाहिश होगी कि आप इसको लीड लें, ताकि हम जैसे लोगों को अपने घर जो है प्लेज ना करने पड़े। तो मेरी ख्वाहिश होगी कि आप इसको जरूर ले लें, और जब आप ले लेंगे आप कहेंगे ना, आपको यहाँ पर आके बैठ दूँगा, जितना अर्सा कहेंगे मैं यहाँ पर ट्रेनिंग करना कराता हूँ। थैंक यू।
Excuse me, allow me, Dr. Yas, just a small, just one question I want to ask. एक तो ये मैं कहूँगी कि डॉक्टर फारूक को ये उनकी शौक का कोई मोल नहीं होगा, तो एक तो ये बात है। दूसरी कि मीडिया में एक आई थी बात कि बिकॉज ऑफ द सम मिस्टेक ऑफ द टेली सर्जरी में जब हमें कंट्रोल कर रहा था, तो रोबोट से कोई मेजर वेसल कट होगी एंड द पेशेंट डाइड ऑन द टेबल। सो अगर इस तरह की इमरजेंसी हो जाए तो क्या वहाँ पे सारी टीम आपकी मौजूद होती है उसको कैसे करने की?
Naturally, the patient is not left alone. The team is there. और मैंने बताया कि अभी बहुत अरसे के बाद मैंने फैसला किया, आफ्टर आई हैड डन 100 केसेस रोबोटिक, तो मेरा फैसला पड़ा कि मैं दूसरे कमरे में बैठ के कर सकूँ। बट यस, द एनेस्थेटिस्ट इज देयर एंड अब अ सीनियर मेंबर ऑफ द, ऐसा नहीं हो सकता मतलब पेशेंट्स जरूरी रखें। अगर जब टेलीसर्जरी भी हो रही होती है, क्योंकि ये ऑलरेडी फ्रॉम न्यूयॉर्क टू पेरिस ये असर आपको पता नहीं सर्जरी कर चुके हैं टेलीसर्जरी, तो अगर वो भी तो जहाँ पे सर्जरी हो रही है वहाँ पे सर्जिकल टीम हो जाएगी। थैंक यू।
Skillful and thoughtful. Now for another state of art lecture, I am honored to introduce an excellent academician and teacher of medical teachers. He has dedicated his life to excellence, innovation and research in the field of surgery. He has trained hundreds of surgeons all over Pakistan. He has served as head of department, King Edward Medical College, principal Fatma Janah Medical College, principal Lahore Medical and Dental College. Articles to his credit about all humble, soft-spoken, innovative and excellent surgeon. Eager to listen the words of wisdom and insight from him. I request Professor Majid to please come on stage for his state of art lecture, Demise of Clinical Acumen.
Bismillahirrahmanirrahim. Assalamu alaikum, ladies and gentlemen. I'm really very proud of Professor Mahmood Ilyas, that he has always been innovative.
I think I would endorse what he said, that this is the future, that we can't, close our eyes to the future. That's how laparoscopic surgery started and people started condemning us. But we continue. I'm sure he's a pioneer in this country, and he will take this, and of course this is the need of the day. I wish in this country we had plenty of dollars and instruments are available everywhere, because I don't think we have dearth of talent in this country. Very well done. That something for our younger generation to learn from. Today, ladies and gentlemen, you'll be surprised that I'm going to take you back a few things. And this is rather depressing clinical acumen. There were few incidences in this city, and I was really very moved. And I thought of talking to people. Right. Now, I would like to dedicate this talk to my teachers, who plant the seeds of knowledge that will grow forever. Now, recent technological developments have taken its toll on clinical training of undergraduates and postgraduates alike. As a result, very serious lapses are noted day in and day out in patient management. We produced wonderful training across the country in the yesteryears. Our graduates did wonders around the world. Honestly, you provide us with 10 robotic instruments, and people will learn very quickly in the city or elsewhere in the country. There is something which has gone wrong, and we all need to ponder over it and try to find the causes of this malady and think of possible solutions. Now, this presentation is essentially aimed at sensitizing the faculties on this very important aspect of training of our doctors.